it's accumulating.
Yes, we can say that. Yes, here
Yeah.
fluid is able
Yeah.
to pass through here and go here.
Yeah.
But after this, it cannot exit. So
Cannot
fluid
go.
will
Yeah.
here also, probably at the ultimately collection here also. Here, the main thing is fluid is only stuck in the vitreous chamber and it's unable to pass and go across here itself. So that's why see the arrows. I think here most of this arrow are reversed. So most of the fluid collection will be on this side. You're right. I agree. So whatever's remaining here is also not able to exit. But most of this collection is collecting here. It's a reverse flow and collecting in the vitreous side. But basically, some fluid should have been here initially, right? So that also has no pathway to get out. So everything is stuck on all sides.
Both are dangerous condition anyway, front or back. Yeah.
Yeah. The only thing is if this is occurring very acutely, like an acute movement, acute shut, that means pressure will build up very fast, and that's an emergency. So otherwise, this open angle and angle closure are slow chronic processes. And when the patient goes for routine ophthalmologic examinations, there's a machine that detects the pressure, and that will tell us, okay, if they're having glaucoma or not. But then it can occur so acutely that there's complete pupillary block, causing an abrupt angle closure and rapid increase in IOP. So that's when they'll have severe pain, conjunctival erythema as in this patient, sudden vision loss, halos, headache, fixed mid-dilated pupil, nausea, vomiting. Immediately go to the ophthalmologist and they need to get surgical correction or release of this fluid so that it will not cause blindness.
Yeah, I guess in upward situation, basically, although it's obstruction there, but still I think there is some flow from the posterior chamber into the anterior chamber, right? It's not complete blockage, but when the complete pupillary block occurs, that leads to this abrupt angle closure glaucoma, acute one.
Yeah. Yeah. Yeah.
Okay.
Trabecular is basically absorbing the aqueous humor, right?
Yes.
Mm.
This porous thing that we're seeing here, it's actually like a sieve, you see. तो यहाँ से fluid निकल जाएगा थोड़ा थोड़ा करके.
So basically,
अगर block हो गया तो it's resistant. So ये mesh जो है गंदी हो गई, or like you can say, just to understand and remember, this mesh is now occluded. So there's no way for this tea to filter anymore.
Yeah, makes sense. That is better. Nice.
That is better. Huh?
Yeah.
हमने सारी
चाय की पत्ती का जो sieve is
पत्तियां
there,
भर दिया उसको.
Yeah.
कहीं जा ही नहीं सकता ना, तो भर गया पूरा वापस. So that tea is remaining in the other side. So that's this an example. This is a mesh work. It's supposed to drain the fluid out and then take it out through the episcleral vessels. यहाँ से वहाँ जाएगा, vessels में जाके पहुंचेगा, and then it'll get out of the eye. Now there's no outflow, so drainage problem. Yeah,
so increased trabecular outflow, then to the कहाँ से canal of Schlemm से जाके episcleral veins में जाके drain हो रहा है, ठीक है?
Exactly.
और वो कहाँ जाके खुलेगी?
Good question. That episcleral
Dural
veins
venous
or
sinus.
something. हाँ, yeah.
Ophthalmic veins or cavernous sinus and then into transverse something.
क्या कहाँ open होगा
ये जो यहाँ पर drain हो रहा है, aqueous humor जो drain होगा, via canal of Schlemm into the episcleral vessels, right?
Right.
And then they go and drain into your ophthalmic veins में I think जाके खुलेगा.
Ophthalmic vein, that lymph pathway that we saw?
I think so, yeah.
Oh, yeah, no makes sense. Thank you. Episcleral, okay, then goes.
Where does it go? Remind me, please. Where did we see?
Dural venous sinuses में
Dural venous.
Oh, right. Yes, we saw it yesterday. Makes sense. Wow.
That's really nice.
You're right.
Amna ka connection na tak. That really works well.
Honestly, please confirm. I'm not sure.
Yeah, you're right. Makes sense.
Makes sense.
Ophthalmic veins, phenopharyngal sinus, and then I think, yeah. the
That's
cavernous sinus optic.
very nice. Very nice.
Thank you.
Thank you.
So ultimately, it has to go somewhere. No?
Yes, thank you so much. We all saw clicking for all of us. Look at this.
New acceleration.
Yeah, I know.
I
When
know.
Harvey said it was like, हाँ कुछ तो है क्या है? And then when we found, हाँ यही तो था.
Exactly.
Yeah, so
Okay.
it's draining into superior ophthalmic vein finally. Okay.
You're right. So
Super.
aqueous and
I was
epithelial.
so scared मेरे मुंह से गलती से निकल जाओगे.
मैं ज्यादा स्केर्ड हूँ, इतनी सारी गलत गलत चीजें बोल दी.
मेरी तो बेइज्जती होती रहती है guys. So it's okay. Don't get stressed. It's
So,
fine.
Sarah,
We'll learn
Sarah,
together. Fine. It's
Sarah,
Is it
can you
such a-
go back to the eye picture? What were the three? The superior sphenoid, and the other was
um,
three things.
Dural venous sinuses you are talking about?
Yeah, dural wala, not this.
oh, okay. The picture
Yes.
on this one.
The
This one?
dura thingy, dura, yeah. This is spinoparietal and then sinus, that is, okay. And this is a vein. Superior ophthalmic is a vein. And then cavernous sinus. Cavernous is a sinus. Okay. There are two sinuses and one vein.
Exactly, yeah. So the eye is somewhere here, right? So from those epithelial vessels, it comes
Yeah.
and veins into the superior ophthalmic. From the
Mm.
superior ophthalmic, it will go to the cavernous sinus. From the cavernous sinus, it's again, I don't know if this has connection on this side, but otherwise it goes through this, dumps everything into the transverse sinuses. From the transverse to the sigmoid to the jugular vein, going to the, and so on, and ultimately reaching the right side of the heart. Then everything goes for purification and comes back. So that's
Yeah. Brachiocephalic and all those things.
exactly. Yeah.
Good connections. Yeah. Good.
Nice. Thank you so much. Thanks a lot. Thanks, Hamna. Okay, so that's so of epithelial,
Otherwise, I
ophthalmic,
will.
ophthalmic, dural sinuses. Sorry?
Thanks to you, it was very hard. Honestly, I never totally understand things.
Yeah, I used to memorize all this crap. Anyway, it's very clear.
Yes. Nice. Thanks.
thank you so
And for
much.
the drugs thing, yeah, for
Mhm.
the drugs thing, just a quick review: decreased aqueous humor production, which is from the non-pigmented ciliary epithelium, and we for that we give beta blockers, timolol, acetazolamide, and alpha 2 agonist, right? Like I think brimonidine, which is apraclonidine and brimonidine. And if it passes through the trabecular, we have to increase the trabecular outflow. Then we have to give those alpha 1 agonists. No, M3 agonists. M3 agonists like pilocarpine and carbachol. And if we have to increase the outflow via ureoscleral pathway, then we have to give prostaglandins like latanoprost and carboprost, ibuprost, all these things. Like prostaglandin analogs. Latanoprost, bimatoprost. And what else? These are the treatments. No? Either we reduce the aqueous humor production or we increase the drainage.
Exactly.
That's
Yeah.
it.
That's glaucoma. If you understand
Okay.
that, so we increase the clearance or we decrease the production.
Epinephrine also works. I don't know where epinephrine works. Epinephrine
Through the
via
alpha one, no, maybe. So
maybe.
alpha one's to through the no, actually no, this is alpha 2 we're talking. Epinephrine. Maybe it works through alpha 2 only, alpha 2 agonist, so it'll reduce the production, maybe. Let's see, it'll come up. They mention here epinephrine.
Yeah, epinephrine sympathetic, right? Think like that. It's sympathetic. So sympathetics are what? Alpha 1, beta 1, all those things. So yeah, it comes under aqueous humor side, not to the trabecular side. Yeah.
Agreed, yeah. Because M3 will be parasympathetic. This is the prosta. So it has to be beta, not beta blocker, probably through the alpha 2 pathway. But we'll see, I'll check. Let me get to the drugs. So we're good with this, right? Glaucoma. So optic neuropathy caused by progressive vision
sorry.
loss, peripheral to central.
Sorry, alpha epinephrine XY alpha 1. Apraclonidine. Yeah, apraclonidine and
Yeah, alpha 1, beta 1, beta, and alpha 1, beta 1, beta
so by
2,
working
beta
on
2 also.
by working on alpha 1, which is apraclonidine, it decreases it causes mydriasis. You know that, no? Alpha 1 causes mydriasis. So
Mhm.
that's why we don't use in a closed angle glaucoma. And it also works on alpha 2. So by that, it decreases aqueous humor production.
Mm.
Don't think you can use
was-
alpha 1. You have to use alpha 2 because you need a negative effect, right?
Mm. No, but epinephrine had one more than the other, right? What was it? What was more than other?
Beta 2. But here in this scenario, alpha 2. Yeah, I mean,
Alpha portion is the useful one.
well, alpha is more useful. Alpha 2.
Okay.
Alpha and beta 2 also, beta 2 receptor. Yeah, stronger beta 2 receptor.
Mm-hmm.
Affecting ancillary bodies.
The dose was also different, this epinephrine wala. So maybe we go higher dose, so it has more alpha 1 effect. Is that what we're saying? Alpha 1, beta 1, I don't know. But then why would we give, what about the rest of the body then? Sorry, can you guys repeat, what did you say? By giving what was that? A drug, that one, which you said?
Yeah, Sarah, it's in the last page of, sorry, for the visual memory, last page of Neuro, glaucoma drugs.
Okay. Where is this cardio?
Cardio, neuro.
Neuro. Yes. Epinephrine alpha 1 decreases aqueous humor synthesis via vasoconstriction. So that's how its mechanism. Okay. This is what you're saying. Apraclonidine and brimonidine by alpha 2. So what is alpha 2 doing? Decreasing aqueous humor synthesis, increasing aqueous outflow pathway. Okay.
Okay, so alpha 1 and vasoconstriction.
So by vasoconstriction, it's just shutting the openings, so decreasing the synthesis of that.
Yeah, decreasing the synthesis. So we have 4 drugs for decreasing synthesis, right? One is beta blocker, alpha 2 agonist, and carbonic anhydrase, and also epinephrine.
Correct. Yeah, we should add epinephrine on that pink box.
But then you have to be careful. You cannot give for glaucoma. That's all.
Yeah.
Otherwise, it's okay. Yeah.
In open angle, close angle is contraindicated.
Yes. So in acute open angle chronic we can give, but it's contraindicated in the closed angle one. Close or narrow angle, we should not give it. Okay. So epinephrine will only come for, that's why they probably didn't put it in the box. Okay, so let's do the drugs also. Then let me finish the reading one more time and then we'll do the drugs so that it's all together, consolidated instead of going back and forth. Glaucoma. Okay, so what was glaucoma? One more time, optic neuropathy causing progressive vision loss, peripheral more than central, usually but not always accompanied by increase in intraocular pressure. Etiology is most often primary, but can be secondary due to an identifiable cause like uveitis, glucocorticoids. Fundoscopy will show optic disc cupping, normal, which is we said less than 0.5, versus thinning of the outer rim of the optic disc. Thinning of the outer rim is known as a phenomenon known as cupping. Then treatment is pharmacological or surgical lowering. So in a few, we'll see the pharmacologic treatments. First, we have open angle type, acute angle closure, open angle glaucoma. Second subtype is angle closure or narrow angle glaucoma. I think the older books, they used to say narrow angle. Closed angle or angle closure, narrow angle is all the same, synonyms. Okay, so open angle glaucoma, what does it mean? The anterior chamber angle is open, most common type in the US, associated with increased resistance to aqueous humor drainage through the trabecular meshwork. Risk factors: increasing age, race, increase in sense in Black population, family history, DM. Typically asymptomatic and discovered incidentally. Then we have acute angle, angle closure glaucoma. So by definition, the anterior chamber angle is narrowed or closed, associated with anatomic abnormalities like an anteriorly displaced lens resting against the central iris. So there's decreased aqueous outflow, decreased aqueous flow through the pupil, pupillary block is there. Pressure builds up in the posterior chamber, peripheral iris is pushed against the cornea, obstruction of drainage pathway by the iris, and usually chronic and asymptomatic. Usually it's chronic and asymptomatic, but may develop acutely. So one is anatomic abnormality. 2 is decreased outflow through the pupil. 3, pressure buildup in the posterior chamber. 4, iris pushed against the cornea. Number 5 is obstruction. If it occurs acutely, then it's acute angle closure glaucoma, complete pupillary block, causing abrupt angle closure and rapid increase in IOP. Presents with severe pain, conjunctival erythema, sudden vision loss, halos around the lights. Headache and fixed mid-dilated pupil, nausea, vomiting. Hurts in a hurry with halos and headache and half-dilated pupil. It's a true ophthalmologic emergency that requires immediate management to prevent blindness. Mydriatic agents are contraindicated in acute angle closure glaucoma, or even in general angle closure. So epinephrine will be a mydriatic, so we will not give it. So now going to the drugs for glaucoma.
So there are 4 points you read. Where did you read that from? About the structural problem and all those things.
Something I just put it in points.
You put it together, that was very nicely said, actually.
I just like to put it in points, consolidates my head. I can repeat it. So number 1 was anatomic abnormalities, where the anteriorly displaced lens resting against the central iris. Number 2, there is a decreased aqueous flow through the pupil, causing a pupillary block. Number 3, because of this, pressure builds up in the posterior chamber. Number 4, peripheral iris is pushed against the cornea. Number 5, obstruction of the drainage pathway by the iris. And now this is now it's the angle closure glaucoma. That's it. Okay, then coming to glaucoma therapy, we have decreased intraocular pressure via decreasing the amount of aqueous humor. Sorry, is someone saying something?
Thanks, you did good.
Okay, thank you. So decrease IOP via decreased amount of aqueous humor, inhibit synthesis or secretion, or either inhibits the synthesis and secretion or increasing the drainage. So 2 options. So we decrease intraocular pressure via decreasing the amount of aqueous humor. How do we decrease the amount of aqueous humor? Either we inhibits its synthesis or secretion, or we increase the drainage. So bad humor may not be politically correct. So BAD, so beta blockers, alpha agonists, diuretics, prostaglandins, cholinomimetics. So this should be BBAA, BB, beta blocker, AA, alpha agonist, then diuretics, prostaglandins, cholinomimetics. Because then I'll sit in the later and be like, was it beta agonist or beta blocker? Let me see, 570. Okay. So first we have beta blockers, timolol, betaxolol, and cartiolol.
Saya, just a suggestion. It's a difficult thing, I know. So can you please categorize according to the decreased, first one decreased aqueous humor synthesis, and then the drainage according to the drainage drugs, right? Which blocks the drainage, which increases the drainage. Because I've tried, it's general Mangala. After that, they have written it very haphazardly.
Okay, so first, whichever is decreasing the synthesis. So beta blockers is decreasing synthesis. Alpha agonist is decreasing synthesis. These are also decreasing synthesis. Diuretics decreasing synthesis. So these are that's it. So number 1, what are the drugs decreasing synthesis? We have beta blockers, timolol, betaxolol, cartiolol. Decreasing aqueous humor synthesis, safe drugs, no pupillary or vision changes. Then among the alpha agonists, we have epinephrine And we have apraclonidine and brimonidine, which are alpha 2. So this alpha agonists are further divided into our alpha 1 and alpha 2. So they all decrease aqueous humor synthesis. So no, epinephrine only will decrease aqueous humor synthesis via vasoconstriction, as well as apraclonidine and brimonidine also decrease aqueous humor synthesis. So if we classify it, if we put a separate chart, decreased synthesis is beta blocker, alpha 1, which is epinephrine, alpha 2, which is apra and brimo, and diuretics. Then coming to step 2. The ones that will increase the drainage. So increasing drainage, again, we have different pathways to do that. If it is increasing outflow via, if it's decreasing outflow via aqueous humor, if it decreases outflow of aqueous humor via the uveoscleral pathway, that one is both of these, all of the alpha agonists. Increasing outflow via aqueous humor, increasing outflow of aqueous humor via decreasing resistance. So let's put that in another category. Increasing outflow of aqueous humor via contraction ciliary. This is also another pathway. So each is its own. Okay, let's see. So what are the ones that are increasing outflow is? Number 1, alpha agonists. Number 2, prostaglandins. Number 3, cholinomimetics. But each is having its own pathway. So alpha agonists, how do they do it? Via the uveoscleral pathway, which we saw was the 10% wala stuff. Then prostaglandins are increasing aqueous humor by decreasing the outflow of this uveoscleral pathway as well. So this is also the same thing. But it's decreasing the resistance of flow. So that's the second one. And third thing, cholinomimetics increase aqueous humor via contraction of ciliary muscle. So it is opening the trabecular meshwork. So these 3 drugs, they're all increasing the outflow, but how do they do that is different. So if we have this uveoscleral meshwork, no, actually that was the trabecular outflow. So uveoscleral was the 10% going into the uvea and sclera. Okay, so one is increasing the outflow via uveoscleral pathway, which is an alpha agonist. Prostaglandins is decreasing the resistance so that it can flow more. Cholinomimetics is contraction of the ciliary muscle and opening the meshwork. Okay. So then actually before that, this previous category which we saw, aqueous humor was decreased by a vasoconstriction for alpha agonists, like specifically epinephrine. This is also decreasing aqueous humor synthesis, but via carbonic anhydrase inhibition. Then use of pilocarpine in acute angle closure glaucoma. This is very effective at opening the meshwork. So this is pilocarpine in acute angle closure. This, what is it doing? It's opening the meshwork in the canal of Schlemm, specifically working in the canal of Schlemm. To open that canal of Schlemm. So the image that we saw, it's going to open it. What's this page number? 570. Does anyone have our page number for let me say press biopsy? I should put it. Now we're on 572. So this canal of Schlemm, which was there, pilocarpine is specifically working on the canal of Schlemm. Okay. So let's take it from the top. First, we have the drugs BBAA DC. So beta blockers, AA alpha agonist, DTC. Diuretics, prostaglandins, cholinomimetics. Beta blockers, what are the drugs? We have timolol, timolol, betalol, cartiolol. Tim beta cart. So these will decrease the aqueous humor synthesis. No pupillary or vision changes. So this is safe. Okay. Then alpha agonists, we have alpha 1, alpha 2. Alpha 1 is epinephrine. What is it going to do? It's going to vasoconstrict. So it decreases aqueous humor synthesis. The caveat is it will cause mydriasis because epinephrine will cause mydriasis because epinephrine is flight. It will cause mydriasis. So do not use in closed angle glaucoma, contraindicated. Other side effects, blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reaction, ocular pruritus. Okay, allergies, pruritus, all that. So the other alpha 2 were apraclonidine, brimonidine, which are both alpha 2. What do? They will decrease aqueous humor synthesis. The other thing they do is increase outflow of aqueous humor via the uveoscleral pathway, which is this 10% wala outflow from uveoscleral pathway. So we saw it here also.
And this one it does via alpha 2, right?
Yes, alpha 2. Mm-hmm.
So decrease aqueous humor synthesis via alpha 1. Right?
Yes.
So
via vasoconstriction.
uveoscleral
pathway, na?
Yeah,
Which one are you talking about?
So alpha 1 and alpha 2, different functions. Alpha 1 decreases aqueous humor synthesis via vasoconstriction, epinephrine. And apraclonidine and brimonidine, which is alpha 2. So it has both functions. It decreases aqueous humor synthesis and increases outflow of aqueous humor via a uveoscleral pathway, right?
Yes.
Okay, thank you.
Yeah.
So epinephrine via alpha 1 only decreases the aqueous humor production. It's the alpha 2 agonist, which basically decreases aqueous humor synthesis and increases the outflow through the uveoscleral pathway.
Exactly. So that's what even I paused to think, because epinephrine will not increase the outflow. It's not possible. So these second bullet, these two are the functions of the alpha 2. So yahan tak epinephrine is done. So apraclonidine and brimonidine are doing two things. One, they decrease the synthesis. Two, they increase the outflow. So they're doing both pathways. So then these are common side effects to all of these are blurry vision, ocular hyperemia, foreign body sensation, ocular allergic reactions, ocular pruritus. Then next we have diuretics, acetazolamide. What do these do? They are the synthetic enzyme blockers. So decrease aqueous humor synthesis by inhibition of carbonic anhydrase. No pupillary vision change, again, no side effects, not as much. Then we have prostaglandins, bimatoprost and latanoprost. What are these classes of drugs? PGF2 alpha. So what do? They increase outflow of the aqueous humor via decreasing the resistance to flow through the uveoscleral pathway. So again, these are also working in this 10% uveoscleral pathway. So what does it do as a side effect? This darkens color of iris, browning, and eyelash growth. which are used in all these serums these days that they market. Darkens the color of iris and causes browning and eyelash growth. So prostaglandins, bepatoprost, latanoprost, FGF2 alpha. So they are also working on the UV-scleral pathway. Then we have cholinomimetics. Then again, we have two subtypes. Either we have direct or we have indirect. Direct is pilocarpine and carbachol. Indirect is physostigmine icothiophyte. So what do? They increase aqueous outflow, aqueous humor via contraction of the ciliary muscle and opening of the trabecular meshwork. So these are the only category that is working through this trabecular meshwork. So whether they are direct or indirect, they will increase aqueous outflow humor via contraction of the ciliary muscle. So by contracting this, they are opening this trabecular meshwork. They are working actually in the ciliary muscle and contracting it and opening this trabecular meshwork. Pilocarpine is specifically for acute angle closure glaucoma. It's very effective at opening the meshwork into the canal of Schlemm. So it's going to work here. So they have shown the carbachol and pilocarpine works in the canal of Schlemm. So here, what are the side effects? These are miotic agents. So they'll cause contraction of the pupillary sphincter muscle and cyclospasm, contraction of the ciliary muscle. So one more time, meiosis, because they're contracting the pupillary sphincter. We said already, what is the pupillary sphincter? The iris ka part of the muscle, which is the circular one. So by doing that, it's going to cause meiosis and cyclospasm, but contracting this so much that there is contraction, spasm of the ciliary muscle. So accommodation will be lost temporarily. So that's cholinomimetics, M3 agents, direct pilocarpine carbachol, indirect physostigmine icothiophyte. Increase the outflow of aqueous humor via contraction of ciliary muscle and opening of the trabecular meshwork. Use pilocarpine in acute angle closure glaucoma. Why? Because it's very effective at opening the meshwork into canal of Schlemm. Side effects, meiosis, contraction of pupillary sphincter muscles. Meiosis, why? Because of contraction of the pupillary sphincter muscles. And cycloplasm because of contraction of the ciliary muscles. Makes sense, right? Physostigmine will come under parasympathetic. So that's what they normally do, right?
Yeah, but how come contraction of ciliary muscles? These people are, this is parasympathetic.
Correct.
Yeah, so parasympathetic
remember,
helps in accommodation. Yeah, helps in reading, right?
Okay.
Remember how we said the muscle will contract to cause these fibers to relax, and then the lens will become, what is the word they used?
Because the iris is the one which is stubborn now. So it has to relax the iris. That's what the parasympathetics do, right? Where is that? Somewhere we said that
is going to work on these zonular fibers. Remember, I think it was on the presbyopia image. Let me see.
Yeah. Parasympathetics.
So it's going to work on. So when we are relaxed or super relaxed, in other words, which is the parasympathetic, ciliary muscle relaxes, zonular fibers tighten.
Tighten, yes.
And
that is relaxed.
Of the lens.
Yeah.
Yes. So this will be tightened. This in front is iris. So here we are talking that we're giving physostigmine, which is going to increase acetylcholine. So it is going to cause meiosis.
Yeah.
And it's going to cause cyclospasm, which is contraction of the ciliary muscle in this way. Contraction of the ciliary muscle and relaxing the zonular fibers and causing thickening of the lens. So we are accommodated. Eye is accommodated because when we are resting, digesting, and reading, we want accommodation, right? We want to sit and read. So accommodation. So that's what they're saying, right? Cyclospasm because contraction of the ciliary muscle. Makes sense. That's matching, right?
So basically in open angle, we have more of resistance to the trabeculae. That's what we studied. So that's what now you're putting it together, saying that the trabecula is nothing but all these guys, right? The ciliary muscles, zannular fibers, all these are being acted upon by the parasympathetics to relax it. Yeah. Okay.
Yes.
Okay.
Correct. Going back.
Parasympathetics to contract them, because ciliary muscle contraction leads to accommodation, right?
Parasympathetic will contract the ciliary muscle, making the eye accommodate. Correct. Yes. Agreed.
Yeah. Oh,
It
yeah.
will relax. Only thing that relaxes is the zonula fiber.
Yeah.
Yes. Agreed. Correct. Am I right?
Agreed.
Yes. Sarah, can I summarize, please?
Yes. Go ahead. Go ahead.
Okay. So, 4 drugs we have, right, for decreased aqueous humor synthesis. Either we need to decrease aqueous humor synthesis or secretion, or either we have to increase the drainage. To decrease aqueous humor synthesis, we need beta blockers, right, which are safe, timolol, betaxolol, cardiolol, right, or the bad mnemonic and the bad humor may not be politically correct. So beta blockers decreases aqueous humor synthesis. And alpha blockers, we have alpha 1 like epinephrine. It decreases aqueous humor synthesis via vasoconstriction. And the alpha 2, we have apraclonidine and brimonidine. They decreases aqueous humor synthesis also, right? Epinephrine causes vasoconstriction. Via vasoconstriction, it decreases. And the apraclonidine and brimonidine also decreases aqueous humor synthesis. I don't know the mechanism, right? So acetazolamide, it also decreases aqueous humor synthesis. So bad and the mnemonic bad basically beta for decreasing aqueous humor synthesis, right? If I'm not wrong.
Yes. Right.
Yeah.
Beta
You're
blockers,
doing good. You're doing
alpha,
good. Yeah.
beta blockers, alpha, either alpha 1 or alpha 2, and D for diuretics or acetazolamide decreases aqueous humor synthesis by inhibition of carbonic anhydrase. Beta blocker safe, diuretic safe. Alpha agonist epinephrine, we know that it's an sympathetic, so it causes mydriasis, so we don't give an acute angle glaucoma, closed angle glaucoma, and also it causes blurred vision, foreign body sensations, allergic rhinitis. Allergic reactions and pruritus, all these things. Then we come to this increased drainage pathway. So the cholinomimetics, which are M3, the major guns, they basically increase the outflow of the aqueous humor via contraction of the ciliary muscles and opening of the trabecular meshwork. So they decrease the resistance and all these, the 90% flow, we know that it's through the trabecular meshwork. So they increase the outflow of aqueous humor via contracting the ciliary muscles so that trabecular meshwork is opened. And we have direct one, pilocarpine carbachol, and indirect one, physostigmine and ecotherapate. Pilocarpine is very good in treating acute ambulatory glaucoma because it's very effective at opening meshwork into the canal of Schlemm. The only side effects we have, because these are parasympathetics, so they cause meiosis via contraction of the sphincter pupillae muscles, and cyclospasm because of contraction of the persistent accommodation, you can say. So cyclospasm, contraction of the ciliary muscle. The other ones, which are prostaglandins, they also increase aqueous humor drainage via decreased resistance of flow through the uveoscleral pathway. We have PGF2 alpha, latanoprost, bimatoprost, and it darkens this is not a side effect, basically this is a good thing. It helps in eyelash growth, and it darkens color of the iris. So browning is occurring and causes eyelash growth, right? And the other one which helps in increased aqueous humor drainage is your via uveoscleral pathway is your apraclonidine and brimonidine, if I'm not wrong.
Yes.
Right, so 3 things causes Increase aqueous humor production. Increase drainage of the aqueous humor. Alpha-2 agonist via uveoscleral pathway, which is apraclonidine, brimonidine. PGF2 alpha, they decrease the resistance to increase flow through the uveoscleral pathway. Latanoprost and bimatoprost, and M3 agonist. Direct or indirect both. Via contraction of the ciliary muscle opens the trabecular meshwork.
Nice.
1, 2, 3. So bad ones basically are the good ones. They decrease the aqueous humor synthesis.
Yes.
Right. 3 drugs
Yes.
basically help in decreasing humor.
Alpha-2 prostaglandin M.
Yes.
ATM is increasing the drainage.
Yes. So
EAD.
3 drugs help in, 3 drugs help in decreasing aqueous humor synthesis. 3 basically helps in aqueous humor drainage. Prostaglandins, alpha-2 agonists, and M3 agonists.
Out of these 3, 2 are from the uveoscleral, which is the A and the P, alpha-2 in the prosta. M3 is the trabecular outflow. Nice.
Big guns, M3. Yeah.
Cool. Nice. Thank you so much. That was nice.
Thank you.
All right, cool. So that's done with glaucoma. Are we all good? Kind of, sorta. Okay. So then
I just noticed that there are 3 decreasing, but increasing only 1 if you go by alpha and beta agonist and antagonist. But prostaglandin is going to increase, and also the clonidine thingy. They are going through uveoscleral pathway. Those 2 are different, but the other 2 are parasympathetic and sympathetic. So there is only 1 for parasympathetic. Is that correct? That is the
trabecular outflow, parasympathetic, right?
That's only 1. Yeah. Cholinomimetic.
Correct.
Okay. Just want to just. Okay. Thanks.
Only 1 where the M3. Only the M3 group is going to do work on the trabecular outflow by contracting the ciliary muscle. So under M3, we have either direct or indirect. But I think they will not test that like that. They're direct because they are directly cholinergic. They're indirect because they increase the cholinergic level by preventing the breakdown. But that's not important in this case scenario. It's more like further farm.
We got the general picture. That's great. Good summary. Good summary. Both of you.
Thank you. Direct would be pilocarpine and carbachol, PC. This is a P and E. Okay, cool. So next, okay, that's done with glaucoma. Where we 5:35 maybe. So done with glaucoma treatment. Next, we're going to retinal disorders. So what are the retinal disorders? We have age-related macular degeneration, diabetic retinopathy, hypertensive retinopathy, retinal artery occlusion, retinal vein occlusion, retinal detachment, pigmentosa, ROP, and papilledema. And we have all these images: retinoblastoma, leukorrhea, uveitis. We'll go to pupillary control. Okay. So first we have age-related macular degeneration. This is the degeneration of the macula. What is the macula? This is the central area of the retina. And the central area of the macula is the fovea. So we have the retina. The central area of the retina is known as the macula. The central area of the macula is then known as the fovea. Just reorienting myself. So age-related macular degeneration is degeneration of this macular layer, which is the central area of retina, leading to loss of central vision known as scotomas. 2 types exist, dry and wet. Dry is the most common. There's gradual decrease in vision with subretinal deposits, which are known as drusen. Subretinal deposits known as drusen. This yellowish structure is the drusen. Then we have wet AMD, which is rapid decrease. So this is gradual decrease. So it's dry. This is rapid decrease due to bleeding, secondary to choroidal neovascularization. This has blood, which is why it's wet. So it's secondary to what? Choroidal neovascularization. So we know choroid was the layer with all the vessels, then supplying the retina. There's lots of new vessels coming here, and those are rupturing and bleeding. So that's the cause of the wet AMD. There's distortion of straight lines, known as metamorphosia, which is the early symptom. Okay, interesting. So if I saw a straight line, if I see it distorted, that means I'm starting to have wet age-related macular degeneration. All right, so that's AMD, degeneration of macula, central area of retina, leading to loss of central vision. And that's when you lose central vision, it's known as scotomas. There are two types, dry and wet. Dry is most common, gradual decrease in vision with subretinal deposits, drusen. Next, we have wet subtype, wet AMD, rapid decrease in vision loss due to bleeding. Secondary to choroidal neovascularization. So bleeding, that's why it's wet. So it has, from where is the bleed coming? Secondary to choroidal neovascularization. Distortion of straight lines or metamorphosia is an early symptom. Then we have diabetic retinopathy. Here, there's chronic hyperglycemia, increased permeability and occlusion of retinal vessels. So diabetic retinopathy, what happens? Chronic hyperglycemia, increased permeability and occlusion of retinal vessels. Two types, non-proliferative and proliferative. So non-proliferative is the most common. Microaneurysms, hemorrhages, cotton wool spots, and hard exudates. So vision loss is mainly due to macular edema. So one more time, non-proliferative is microaneurysms, hemorrhages, seen in B, just little bleeding points. Cotton wool spots, hard exudates. So vision loss is mainly due to macular edema. Then the proliferative types. What is proliferating? Retinal neovascularization due to chronic hypoxia. Abnormal new vessels may cause vitreous hemorrhage and tractional retinal detachment. Okay, so one more time, diabetic retinopathy. This is because of chronic hyperglycemia. It leads to increased permeability and occlusion of the retinal vessels. So yeah, osmotic draw kind of a situation. So increased permeability, occlusion of retinal vessels. Two types are there, non-proliferative, proliferative. Non-proliferative is most common. What do we see? Microaneurysms, hemorrhages, cotton wool spots, hard exudates. Vision loss may be due to macular edema. Then we have the proliferative subtype. Here, there is retinal neovascularization due to chronic hypoxia. Abnormal new vessels. So yeah, proliferative means what is proliferating? That should have a sting. That is the retinal new vessels. Why are they proliferating? Because there's chronic hypoxia. Abnormal new vessels may cause vitreous hemorrhage and tractional retinal detachment. Then next we have hypertensive retinopathy. Here, chronic hypertension, as we know, is the cause. Chronic hyperglycemia. Here we have chronic hypertension. Leads to spasm, sclerosis, fibrinoid necrosis, again, of the retinal vessels. So fibrinoid necrosis from pathology, Dr. Sattar, we know, anytime the blood vessel starts dying, it's going to have fibrinoid necrosis. Endothelial damage, fibrinoid necrosis of the vessels. Here we're in the eye, so retinal vessels. The lots of pressure going on in the blood vessels, damaging the endothelium. So it causes fibrinoid necrosis of the vessel. So here we're talking about retinal vessels, fibrinoid necrosis of retinal vessels. Fundoscopy will show us what? Arteriovenous nicking, microaneurysms, also overlapping with this, hemorrhages overlapping, cotton wool spots overlapping, hard exudates also overlapping, which may form a macular star in this one, this macular star, like the corona radiata type thing. This is also a starburst appearance. Whereas you see in the bone also yesterday, recently we saw, what is it? Sunburst. Sorry, that was sunburst. So this is macular star. Presence of papilledema is indicative of hypertensive emergency and warrants immediate lowering of BP.
What's the picture here, Sarah, for this diabetic retinopathy here? Anyhow?
They've only shown the
This one?
hemorrhage. This, if you see closely, this little bleeding point is for hemorrhage. Here also there's a hemorrhage. I think this is not very clear, but apparently there's an hemorrhage here. So that's what you're supposed to pick up. They have not shown the cotton wool spots. Cotton wool spots are like this. So it'll be same in diabetes also. And this is the macular star. It's like a star is bursting, right? So that's with hypertension. Presence of papilledema is indicative of hypertensive emergency and warrants immediate lowering of blood pressure. Presence of what? Papilledema. If is indicative of hypertensive emergency and warrants immediate lowering of BP. Yeah, this is end organ damage. We studied it, right? So that's hypertensive retinopathy. Let me see some cotton wool spots. So these fluffy, looks like cotton wool. Cotton wool of the brain of the skull was what? Shruti had once told us. I forget.
Paget.
Yeah, thank you. That was Paget for the skull. But here, if you see these little fluffy things in the eye, I'm sorry, in the retina, in the fundoscopy, then we're looking at either hypertensive retinopathy or diabetic retinopathy. Yep. So this, yeah, cotton wool spots on the retina for both of these. Okay. So
I think
that's
you would have good images for all of these situations. And okay, first we do this and then I think.
yeah, we'll look at image reviews in the end. Yeah, we'll finish this. Okay, so next we have retinal artery occlusion. So what is retinal artery occlusion? The artery is the blockage of central or branch of retinal artery, usually due to embolism. Where is embolism coming from? Carotid artery atherosclerosis, more than the cardiogenic. So blockage of the central or branch retinal artery. Less commonly due to giant cell arteritis. Presence with what? Acute pain. Acute painless monocular vision loss. Fundoscopy will show cloudy retina with cherry red spot at the fovea, which is this. Identifiable retinal emboli with like cholesterol crystals appear as small yellow refractal deposits in arterioles. So what are we seeing is this. If they look closely, the ophthalmologist is supposed to see little cholesterol clefts in the vessels. So the main thing is a cherry red spot at the fovea. Okay, so one more time, what is retinal artery occlusion? Blockage of the central or a branch retinal artery, usually due to embolism, which means it's coming from somewhere else. Where is it coming from? Carotid artery atherosclerosis, more than cardiogenic, and less commonly due to giant cell arteritis. Presence with what? Acute painless monocular vision loss. Fundoscopy will show us what? Cherry red spot at fovea. Identifiable retinal emboli, cholesterol crystals may appear as small yellow refractal deposits in the arterioles. Okay, then we have retinal vein occlusion. So vein occlusion, what's the problem? Retinal veins are occluded. Central retinal vein occlusion is due to primary thrombosis. Central retinal vein occlusion due to primary thrombosis. Branch retinal vein occlusion is due to thrombosis at the AV crossings. One more time. Central is due to primary thrombosis. Branch is due to secondary thrombosis at the AV crossings, like sclerotic arteriole, compressing adjacent venule, causing the turbulent blood flow. Okay, central retinal vein means the thrombosis is in the vein itself, primary thrombosis. Secondary means thrombosis at the arteriovenous crossings, where the artery is interjecting with the veins at that junction. There is a sclerotic arteriole compressing the adjacent venule, causing turbulent blood flow. So fundoscopy, what will we see? Retinal hemorrhage and venous engorgement. So blood and thunder appearance for retinal vein. Retinal edema in affected areas. So where is this blood and thunder appearance? Is this. So we are having blood and it's like thunderous. So that's the retinal vein. Versus retinal artery was showing the cherry red spot. And potentially some clefts, which is not shown here. Here, this blood and thunder, when we see with lots of these little dots, bleeding, 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 then we know we're talking about retinal vein occlusion. Although these are all
very confused.
and
These, I don't know why, but these does not stick. I don't know why. It's just my problem. All these things.
they are difficult. So Aftal is tricky. You have to visualize it more. So these veins, which will be straight, here they're bleeding, bleeding. So that's why looking like thunder. So one more time from the top. So far we've done age-related macular degeneration. This was showing a drusen. Here we were seeing what was B?
One thing, sorry. In these retinal disorders, so especially in age-related macular degeneration, we have central vision loss. But we saw in glaucoma, it's the peripheral vision loss. So starting from the periphery, and then it comes to the central, right?
In glaucoma, yes, correct.
So peripheral vision is lost first, then central. But in these, I think central vision is lost, I think, mostly,
correct.
Right?
Anytime the retina or the macula is involved, it will be central vision first. Yes, agreed.
Okay. Thank you. And fovea, you said it's the area where the cones are
only
predominant,
cones.
right?
Yes, only cones, and is the area of highest visual acuity.
Okay. And cones and rods are cones for, there's difference between rods and cones, something, right?
So there are different photoreceptors. One was for, I think cones was for, one was for bright vision, one was for the dim vision, something. Let me check.
Okay. I think the rods maybe in the night.
Because when you have vitamin A deficiency, something goes more or less, something like that. Let me check. I've forgotten it. Rods are responsible for vision at low light levels. So in the night, rods for night. Cones are active at higher light levels, photopic vision, capable of color vision, and responsible for high spatial acuity. Central fovea is populated exclusively by cones. So yeah. Okay. Yeah, cone is, so if you zoom in, it's more of the cones in the fovea centralis. So if you see individually the fibers, rods and cones are responsible to pick up lots of light. So during light vision, rods are supposed to pick up during dim vision.
One of them does pigment actually. Night blindness, another one is pigmentation.
Pigmentation.
It does. That's something separate. Yeah, some unique feature they have.
Pigment was the iris, we said it, the pigment epithelium.
No, the night. Just put it at eye color. See cone color. They are responsible for some color. Color vision, they say, right?
Color vision. Yeah.
Yeah, vision.
I read it somewhere, right? Color vision was cones.
Yeah.
Black and white was rods. I think that's what you said. Yeah, because they have rhodopsin pigment. You have 3 rhodopsin primary colors. Yeah, it's coming back. You're
Yeah,
right.
we
Color
studied
vision
in med school long
yeah,
ago.
long ago. Very long ago, yeah. So 3 different iodopsin pigments it has. So that's why it's able to do color vision. Cone cells. Versus rod cells, only one type of pigment, which all contain only rhodopsin.
Black and white.
So, black and white vision, yeah. You're right. Nice. Thank you. Okay.
You need a cane to walk at night, so you'd have a rod. Rod is for night vision, that's why, something like that.
Rod is for night vision, so you need a rod to walk at night. Okay, nice. So this is for black and white. Black and white, rod, night vision, all go together. One
Go by
web.
CC, color and cone, CC.
Color, cone. Yeah, multicolor vision is nice. And their cones are most in the fovea. Okay, cool.
This one is affected in vitamin A deficiency.
Yes,
Night
ma'am.
vision.
Yes,
Night
ma'am.
vision.
Yep.
Rods are
Right.
lost. Yeah. Rods go first, but then if it becomes so chronic, then eventually they start getting cone. Color vision goes. But night vision goes first. Nyctalopia, we used to learn, right, in med school, or I don't know, in school also. Nyctalopia, night blindness, because of deficiency of rods, deficiency of vitamin A. Okay, nice. Thank you for that. So back to where we were. Where was I? Forgot. What did we do? Okay, retinal vision we did, right? Okay, retinal vein occlusion. Central retinal vein occurs due to primary thrombosis. Branch occurs secondary thrombosis at the AV crossings. The sclerotic arteriole compresses the venule, causing turbulent blood flow. So the arteriole, which is, so venule is going in its own. Arteriole scope, it's like compressing it. It's like what do you call, smashing it, kind of. So because of that, sclerotic arteriole compresses adjacent venule, causing turbulent blood flow. Fundoscopy, retinal hemorrhage and venous engorgement, blood and thunder appearance, retinal edema in affected areas. So that's retinal vein occlusion. Next, we have retinal detachment. What is detachment? This is a separation of the neurosensory retina from the underlying retinal pigment epithelium. So the neurosensory retina separates from its pigment epithelium, causing a loss of choroidal blood supply. This we saw, right? Choroid will be there. Uske piche retina will be there. So choroid is supplying blood to the retina, but then if it detaches, it just slides off. So it's not going to receive the choroidal blood supply anymore. It becomes hypoxic and there's degeneration of photoreceptors. So there is 2 types. We have regmatogenous, which is most common, and non-regmatogenous. Regmatogenous is most common due to retinal tears, often associated with posterior vitreous detachment. Increased risk with advanced age, high myopia, less frequently due to traumatic causes. Photoreceptors. So both. Then they said regmatogenous is most common due to retinal tears, often associated with posterior vitreous detachment, increasing risk with advanced age, high myopia, less frequently traumatic. Posterior vitreous detachment over here. Less frequent risk factors are age, advanced age, high myopia, less frequently traumatic. Then we have non-regmatogenous. Here it will be tractional or exudative. So there is fluid accumulation. Commonly presents with symptoms of posterior vitreous detachment, which is floaters and light flashes, followed by painless monocular vision loss, dark curtain. Fundoscopy will show opacification and wrinkling of the DNA. Detached retina. So this one. Change in vessel direction because of this coming over. And this is a surgical emergency. What did they mean, regmatogenous? What does the word mean?
And it's not there in the old book. All new book has so much information. Oh my gosh.
Really?
Yeah, it's not there in my book. I'm just writing notes like crazy.
Okay. Regmatogenous means what? Derived from the Greek word regma, meaning broken. So regmatogenous means broken, where there's small tear or break in your retina. When your retina has a tear or a break, the gel-like fluid in the center of your eye called vitreous can get behind the retina. So that's what they mean. So now if we compile this, oops.
I wish they have given some nice images.
I know.
Yeah, it's so
But this
difficult to
curtain thing,
imagine.
yeah, this curtain thing which is coming down is the retinal pigment separating. I mean the retina separation. Let's see here then. Here we go. So first, as we said, regmatogenous means there's a hole in the retina. So this fluid will go there and collect, and that will separate the retina. That is the regmatogenous retinal detachment. See, retina is just folding over. So that, how will we see it in thing is this whole thing separating. इसका एक layer is peeled off.
सायरा तो रेटिनल की डिटैचमेंट हो गई है, मींस रेटिना के अंदर टीयर आ गया, सो पोस्टीरियर विट्रियस का जो फ्लूइड है वो रेटिना के अंदर एक्युमुलेट हो जाएगा जाके.
Yes, exactly. So you normally this will be a tight seal, right? It's vitreous chamber is where behind the lens up to this retina.
रेटिना.
Uske behind retina we have choroid, behind that we have sclera covering the whole front and back. But then what happens, the retina breaks, so this fluid which was collecting here, it's now gone and collecting behind it. So that's going to push it and make it more and more detached. So the full layer will come off.
Okay.
So yeah. So it starts off with something that's breaking the retina. What is it? Retinal tears associated with posterior vitreous detachment. So vitreous is detaching on the posterior side on its own. So increases with advanced age, high myopia, less frequent. High myopia makes sense, right? Because myopia, we said there's already elongation. The whole eyeball is like elongated. So if it's more and more elongated, somewhere it will nick and start separating. So that's why they're saying high myopia will cause more retinal tear. Non-regmatogenous is when it's tractional or exudative. So there's no tear, but traction, something's pulling it. Or there's an exudate. So there's fluid accumulation. Let me see. This is still regmatogenous. But there's no break in the retina. But somehow fluid is building up either due to exudative process or inflammation. And it's collecting and it's just getting detached. This is a good image. So this is because of traction. Either this get pulled somehow because of some high pressure or movement or injury. This gets detached because of traction, pulling, or exudative or exudation. So this collection, and that's causing the retinal separation.
So is that called non-regmatous?
Yeah, non-regmatogenous. Because the regma, we said in Greek, was break. So this is without a break. There's no break in the retina, but it's separating from the thing. If retina layer itself has a cut, and then from there is where this fluid is flooding into the space, that's a regmatogenous. So in both cases, there'll be painless monocular vision loss because retina's detachments, how will we perceive the vision? So that's the problem there. So painless monocular vision dark curtain appearance, floaters, light flashes are all presentation findings. Fundoscopy will see opacification and wrinkling of the detached DNA. So normally in fundoscopy, we see the normal DNA will be smooth. Here it will be wrinkled and separated. So that's what we'll be seeing. Okay.
So where is the wrinkling, Sarah? Sorry, I don't-
So if you see this wrinkling,
Oh,
this is all wrinkling patterns.
so that's so that
because
looks
the
like a
retina is
curtain.
detached. Yeah, like a curtain.
Okay.
So physically also it looks like a curtain. Even the vision, it'll feel like the curtain is coming in front of the eyes. Because the retina is only getting partial vision, sending signals. So dono will be
पर्दा
curtain.
उठ रहा है ना आँखों से, हाँ ठीक है, पीछे से, okay, thank you.
So one more time, what is retinal detachment? Separation of the neurosensory retina from the underlying retinal pigment epithelium leads to loss of choroidal blood supply. So retina becomes hypoxic, degeneration of photoreceptors occurs. There are two types. One was regmatogenous, which was with the break. So this is the most common type, where there is a starting point is a retinal tear associated with posterior vitreous detachment and increased risk with advanced age, high myopia, and less frequently could be traumatic. So the triggering point is the retinal tears. In non-regmatogenous, it's traction, something that's pulling it, or exudative. So it's like inflammation, cells, something. So there's a fluid accumulation here. That's a triggering point. So both of these commonly present with symptoms of posterior vitreous detachment, like floaters, light flashes, followed by painless monocular vision loss. Dark curtain. Fundoscopy, opacification, and wrinkling of detached retina is seen, which is this one. Anytime you see waves like this, that's the retinal detachment. Then, so yeah, fundoscopy, opacification, and wrinkling of detached retina, change in vessel direction. Because normally if you see these vessels are going like this, but then suddenly because this is skaparda, right, this is going downwards. So changes will be there. And it's a surgical emergency. Next, we have retinitis pigmentosa. What is this? A group of inherited dystrophies causing progressive degeneration of the photoreceptors and the retinal pigment epithelium. So dystrophies, inherited dystrophies causing progressive degeneration of what? Photoreceptors and the retinal pigment epithelium. Photoreceptors means the rods and cones which we saw. So that's getting degenerated. Or the retinal pigment epithelium. That's getting degenerated. So this can be associated with A-beta lipoproteinemia. Early symptoms, night blindness, which makes sense. We said that rods for night blindness, or rods for night vision. So early symptoms will be nyctalopia. Then it will be peripheral vision loss as well. Fundoscopy will show a triad of what? Optic disc pallor, retinal vessel accumulation, attenuation. What's the triad? Optic disc pallor. Optic disc will be pale, as it normally will be brighter, that will be pale. Retinal vessel attenuation. So the vessels which will be normally like this, like prominent, are now very attenuated and thin. Hardly seeing vessels here. Retinal pigmentation with bone spicule shaped deposits, which is this bone spicules. So they're pigmented and they're bone spiculi, bony spots. It's the retinitis pigmentosa. Very thin vessels also. Okay. That's retinitis pigmentosa. One more time.
One more thing, when we talked about the curtain thingy, there is a disease called Amarox fugax. Does it have any relation to this crap? Like, I don't know, or it's something different totally.
Amaurosis fugax is sudden loss of vision. Yeah.
That's also curtain. Yeah.
Yeah, painless monocular loss of vision is actually known as amaurosis fugax. But
Okay.
then that is, I think there's a slight difference.
Yeah.
That will be idiopathic or something.
It's showing up. It's showing up. Yeah. The the crinkles that you were showing. Yeah, something like that.
This is transient loss of vision. I think it may be because of
It's a curtain actually. Again, the same word they
that
use
also
there.
has a curtain. Yeah, curtain
Yeah.
draws over. Yeah, yes, you're right. I think it's coming in the next page if I'm not wrong. Here it is
Okay.
transient. So TIA in the eye basically is the amaurosis fugax. Transient painless monocular vision loss, often described as a curtain coming down.
Okay.
Embolic hemodynamic ocular neurologic idiopathic causes.
Mhm.
Yeah, TIA of the eye is the amaurosis fugax. Let me see.
Mhm. I don't see in my book, so if you can show me. Yeah,
Okay, sure.
it's not there. TIA.
Maybe you all had it actually. Remember somewhere. It is coming up. Yeah, we saw the TIA actually.
Yeah, here it is. Transient. Okay, okay.
Transient visual loss due to retinal artery emboli from coronary artery disease. So TIA happening in the eye vessels is known as amaurosis fugax. They also, you're right, they also present with like a curtain downing sign. Then it will go off on its own.
Yeah,
So
it's
due
in
to
the
retinal
wrong
artery-
place. They have to move this to eye also, or make a copy. Yeah,
Yeah.
carotid artery disease.
Mm.
All right, thank you for bringing it together.
No, you're welcome. Thank you for reminding us about that. Amaurosis fugax. Acutes. Yep. So retinitis pigmentosa, group of inherited dystrophies causing progressive degeneration of photoreceptors and retinal pigment epithelium, may be associated with A beta lipoproteinemia. Early symptoms are night blindness, peripheral vision loss. Fundoscopy is will show a triad of optic dyspallor, retinal vessel attenuation, and retinal pigment epithelium. Retinal pigmentation with bone spicule-shaped deposits. Then we have retinopathy of prematurity. This is preterm birth. This is important. We have like 2 questions on you all, I think. Preterm birth leads to loss of the normal hypoxic environment in utero. So there is a relative hyperoxia, increases with supplemental oxygen for NRDS if they give it, drop in the VEGF, arrest of the normal retinal vascularization. As the eyes grow, hypoxia occurs of the vascular retina, increase in VEGF, then there's retinal neovascularization, which may cause tractional retinal detachment. So this is high, low, high, low, high, low situation. Let's see what happens. So first, in utero, there's low oxygen tension. So the fetus will produce increased VEGF. So that is sustaining the normal vessel growth. So if they have a term birth, retinal vascularization is complete, so they're okay. But if they have a preterm birth and they're outside the mother's womb, there's a relative hyperoxia in the real world compared to the in utero situation. So what happens? This high VEGF suddenly drops because there's hyperoxia, no longer needed VEGF. So what happens is cessation of vessel growth. And as the baby is growing, there's increased metabolic demand. So there's again relative hypoxia and increase in VEGF. So retinal vascularization will be there, but it'll be abnormal. This is known as retinopathy of prematurity. So there's high, low, high again. High VEGF, low VEGF, high VEGF. Low oxygen tension, relative hyperoxia, relative hypoxia. So that is the retinopathy of prematurity. And if we give 100% oxygen, it makes it worse. So we have to be careful here. So preterm birth, loss of normal hypoxic environment in utero leads to relative hyperoxia. increase with supplemental oxygen for NRDS, decrease VEGF, arrest of the normal retinal vascularization. As the eyes grow, there's hypoxia of the vascular retina again, causing an increase in VEGF. Retinal neovascularization occurs, but may cause tractional retinal detachment. This retinal neovascularization is very haphazard, and that can lead to complications, bleeding, retinal detachment, and that can commonly lead to childhood blindness. So that's retinopathy of prematurity. Then the last thing on this page, we have papilledema, which is optic disc swelling, usually bilateral due to increased ICP, secondary to a mass effect. So optic disc swelling is known as papilledema. Usually it's bilateral in both eyes due to increased intracranial pressure, secondary to a mass effect. So we see this in the eye clinically, and we know something's going on badly in the cranium. So results from impaired axoplasmic flow in the optic nerve. So we know that axons are responsible to keep the flow going in the nervous cells, right? So if this axon plasmic flow is gone, things will accumulate and cause the papilledema in the retinal vessels, in the retina, it's in the optic disc. Axoplasmic flow, impaired axoplasmic flow in the optic nerve. So fundoscopy will show elevated optic disc with blurred margins.
We did something on exoplasmic flow yesterday.
There also in the neurons, there will be exoplasmic flow obstruction and axoplasmic. The axoplasm, we saw bulbs, right? What was it? In diffuse axonal atrophy.
Some disease, something. Yeah.
Diffuse axonal atrophy, it was with the traction disease. Remember? The bulbs, there also the flow is lost. That's where I think we saw it. Axoplasmic flow. Let me see.
I think Hamna was the one who just mentioned something yesterday. Exoplasmic.
Diffuse axon, that's the injury. Diffuse axonal injury with the traction, with the accidents. Remember? Okay, this one maybe Hamna mentioned. Idiopathic intracranial hypertension also. Impaired optic nerve axoplasmic flow leading to papilledema. Intracranial hypertension. The other one we saw was the white matter tract separations, that also was having the axoplasmic flow problem.
White matter tract.
The image with the accident, the separation of the white matter, gray matter.
Oh, right. The guy with the coupe, counter coupe. Yeah.
Yeah, that one with the bulbs will be formed.
Excellent. Yes, two places. Coupe counter coupe accident. Yeah.
Yes, that one, as well as the idiopathic intracranial hypertension. There's decreased axonal flow, axoplasmic flow, causing papilledema. Let me double check if I'm correct.
Idiopathic intracranial pressure. What did you say? Idiopathic?
The idiopathic intracranial hypertension. Yeah.
Intracranial. Okay. Hypertension. Yeah. Axonal. I remember very well. Vividly.
Impaired optic nerve axoplasmic flow leading to papilledema.
Yeah. Axonal. Exoplasmic. That leads to papilledema. Thank you so much.
You're welcome. Here,
this is the one. Yes.
Said about the bulbs. Flow is gone. Accumulation of axonal transported proteins over here. Normal axonal transport is inhibited, so leading to accumulation of axonal transport proteins over here. Then within the axonal swellings, so there is an axonal bulb formation. This was the one we saw. But impaired axoplasmic flow, the exact words were in idiopathic hypertension, because that also presents with papilledema. This is slightly different though. Okay. Here the answer was interruption of the white matter tracts. Okay. Impaired axoplasmic flow, papilledema. All right, so papilledema we were doing. So the image shows blurring of the optic let us say elevated optic disc with blurred margins. So if you see this cup margins are like sharp, here the margins are hazy and blurred, and the cup will be elevated. Let me see on Google. This normally will be flat, but then it will be bulging optic disc. And on this fundoscopy, it will show blurry margin of the optic disc. Like this, it's going to be hazy. Then we know we're talking about papilledema. So normal optic cup, optic disc, macula, fovea, the artery and the vein. Compared to papilledema, we have disc hyperemia, redness, peripapillary, so around the papilledema, peripapillary hemorrhage, venous engorgement, disc hyperemia, optic disc swelling with a blurred margin. Okay. So image review, we had the drusen for the wet macular degeneration. Then, why is this like this? Sorry. A was a drusen. B was showing the hemorrhages in diabetic retinopathy. C was showing the macular star and the cottonwool spots. D was showing the cherry red macula, but what was the condition? Then E was the thunder blood appearance with the retinal vein. F was the curtain sign in the retinal detachment. G was the bony spicules. H was the papilledema. So this was drusen of the dry AMD. Hemorrhages in diabetic retinopathy, cottonwool spots, and the macular star for hypertensive retinopathy. Cherry red spot in the fovea for retinal artery occlusion, thunder and blood for retinal vein occlusion, this curtain appearance and changing the direction of the vessels for retinal detachment, bony spicules and thinned out vessels for retinitis pigmentosa, papilledema, elevated optic disc, and blurry margins for papilledema. Anybody home? Hello? Has anyone put everyone to sleep or what?
Yeah.
I'm there.
Oh my
I'm
God,
there.
this is that is so difficult. Oh my God.
I have to make dinner for the family, so I'm thinking it's so important.
Okay. Began to
Okay.
quiet all of a sudden, so I was wondering what's going on. Okay.
Saira,
Should we take a break or what?
yes, we should take a
We
break
will
after
finish
that.
this.
I think we
Shall
should.
we complete this page, but teeny hai bas.
Yeah, this we can finish and then we'll take a break here. So then when we come
Okay.
back, we go for the pupillary control.
Can you summarize this?
आज भी खत्म होगा कि नहीं? Let's
Nahi
see.
ho payega.
Nahi, aaj nahi hoga. I don't think so because there's a lot.
Yeah,
I
we have
saw
farm
there's a
This is
lot.
very hard. Oh my God, this is
So
very
I
hard.
okay,
think
Saira,
at least
kal kar lenge jo
Yeah.
pharma is too much actually.
Palm we'll do tomorrow, but at least soft eye can we do, or should we just stop early? How do we feel
कितना
like?
हो पाता है सामने मतलब see
Actually, retain भी तो करना है ना, obviously.
Yeah.
Because retinal disorders, if you guys retain it
हो
kindly.
जाना चाहिए मेरे
Go
ख्याल से,
through.
बट क्या है ना INO वाला if fresh मतलब INO is the one challenging thing I feel.
Yes, yes,
Uh,
yes.
After INO there is 10 pages of you know
This
11.
glaucoma ka almost one page we finished. So we have this one.
हाँ,
Oops.
Yes, we did something. Yeah, glaucoma.
तो कल के
So
लिए सिर्फ
then,
10
yeah,
ही होगा.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yeah. So then let's just
Easily.
finish and stop instead of taking break, right?
Yes.
हाँ, हम ना
Yeah.
Do we want to stop here? That's what we're saying, right? Stop for the
no
day.
no
No, I just want
Pupillary control.
कि इसको कोई इसको कोई summarize
Yeah,
करो.
we are going to finish summarize. I'm just
No,
while
I
we
think
are
this
listening, what's the
pupillary
plan?
control. I think pupillary control is really high yield. Let's not, let's.
Tyra, what I was saying कि INO 556 पे है, ठीक है?
Mm-hmm.
No, 560
No,
पे.
this is pupillary control and RAPD. So that's the
हाँ,
thing. This is high yield pupillary
हाँ,
control.
right? तो break के
RAPD is
बाद,
high yield.
हाँ, break के
What else
बाद,
we need to do? कुछ easy page कर लेते हैं आज. Then we can do all the tough ones tomorrow fresh in the morning.
हाँ, तो अगर हम ये pupillary reflex से कल करेंगे, तो there would be how many pages? There would be 56,
10, 15 pages. It's not bad.
14 pages would be there. No, 14, 14 would be there.
Easily. You'll do easily.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15 pages. Okay, 15 if you don't, 14 if you don't count the glaucoma page.
Today we did some 15, 16 pages.
14 if you don't count the glaucoma page. So that's decent. I think we can manage. Or we can do just the pupillary control and stop. That also is an option.
मेरे को तो लगता है आगे कर सकते हैं, अगर कर INO को छोड़ के उसके पहले तक कर सकते हैं, if possible.
Because if we do all of the high yield pathways tomorrow, then it'll all be jumbled. This is my thing. So we can release the light reflex today, let it simmer. Tomorrow we'll start with honors and this one, then go to this screening of 3, and then visual pathway, then go to INO. Then we'll probably, by the time it'll be lunch.
You don't like it?
So that sounds good, right? So let's just finish little bone and we'll stop for the day.
Okay,
so
first
summarize
anyone summarize this.
Go ahead. You want to summarize?
Okay, let me. Okay, but I don't know. Please correct me. And the main points, please mark it so that we can remember the main points. Okay, so age-related macular degeneration. I think this is the most important one. So what happens? It's a degeneration of the macula. What is macula? You said it's the central part of the retina, and the center of the macula contains fovea, right? So basically, whenever there is degeneration, it's mostly age-related. So it's loss of the central vision, which is scotoma. Two types which we have, dry and wet. Dry is most commonly due to drusen accumulation. So it's a gradual decrease in the vision with the subretinal deposits. Wet, the cause of bleeding, right? So it's rapid decrease in vision due to bleeding secondary to the choroidal neovascularization. You said that choroidal is the basically vascular structure. So from there, bleeding occurs. So rapid decrease in vision due to bleeding secondary to the choroidal neovascularization. And what happens whenever there is bleeding? So distortion of straight lines occurs. Metamorphosia is an early symptom of that one. Diabetic retinopathy, most starting point is it's a non-enzymatic glycosylation, right? Chronic hyperglycemia, then endothelial dysfunction occurs. Then what happens? Permeability is increased. And the permeability is increased, which leads to occlusion of the retinal vessels. Right? So I think these sugar components go and they will occlude the retinal vessels, right? If I'm not wrong.
Correct. Yep.
Okay. So yeah, non-enzymatic glycosylation occurs and they occlude the retinal vessels. So these are also of two types, non-proliferative and proliferative. Non-proliferative is most common type. And we get like different findings, microaneurysms, hard exudates, cotton wool spots would be there, hemorrhages will be there. And this vision loss here, it's mainly due to Macular edema. Macular edema, why? Because I think hemorrhages are there, so these hemorrhages will obviously due to bleeding. So macular edema will lead to vision loss. Proliferative is because of chronic hypoxia, leads to retinal neovascularization. So abnormal new vessels may cause vitreous hemorrhage and tractional retinal detachment. So retinal neovascularization occurs. Why it occurs? Due to chronic hypoxia. So the abnormal distorted vessels are formed and they cause vitreous hemorrhage, and the non-regmatogenous, this is tractional retinal detachment occurs, it leads to, right?
Yes,
So
exactly.
abnormal vessels may cause vitreous hemorrhage and tractional retinal detachment occurs. Okay, so just I jumped through the retinal detachment because with this. So what is retinal detachment? Separation of the neurosensory retina from the underlying retinal pigment epithelium. So outer layer which you show, so neurosensory retina is detached from the underlying retinal pigment epithelium. So loss of the choroidal blood supply, because the underlying pigment epithelium is supplied by the choroid. When it detaches, so loss of the choroidal blood supply causes hypoxia and degeneration of the photoreceptors, and photoreceptors are your rods and cones. Two types are there: regmatogenous, which is most common. Why it occurs? Because of the tear in the retina. It is often associated with a posterior vitreous detachment. So due to retinal tears often associated with posterior vitreous detachment and increased risk with advanced stage and high myopia, the long eye. So it is less frequently traumatic. Non-regmatogenous, it is due to this diabetic retinopathy, proliferative one, fractional or exudative. So fluid will accumulate over there. Because of these neovascularizations, abnormal neovascularization causes vitreous hemorrhage. So it's non-regmatogenous, fractional or exudative fluid accumulation. Commonly presents with symptoms of posterior vitreous detachment. Posterior vitreous detachment, we have like floaters, high light flashes. So floaters will be there, light flashes will be there, followed by the painless monocular vision loss and the dark curtain. It looks like a curtain is falling down. So on fundoscopy, opacification and wrinkling of the detached retina will be seen, as well as change in the vessel's direction, and it is a surgical emergency. So the buzzwords for it is curtain is coming down, wrinkling of the detached retina, floaters will be there, light flashes will be there, followed by the painless monocular vision loss. Painless monocular vision loss. Then we come to this, and the diabetic retinopathy, proliferative will cause this fractional, non-regmatogenous retinal detachment. Then we have hypertensive retinopathy. It is due to chronic hypertension. It leads to arteriolosclerosis, spasm, and all these things, sclerosis, fibrinoid necrosis of the retinal vessels occur. Fundoscopy, the main differentiating point is AV necking occur. Arteriovenous necking, other symptoms are same: microaneurysms, hemorrhages, cotton wool spots, hard exudates, may form macular star, which is, I think, red arrow in C. Can you show that? Red arrow in C, macular star.
Sorry, this one, right? Star, you're asking?
Yeah. So they form macular star, right? Hard exudates may form macular star. Presence of papilledema is indicative of hypertensive emergency and warrants immediate lowering of the blood pressure. And papilledema, what is papilledema? It's a blurring of the optic disc. It's an optic disc swelling, bilateral due to increased intracranial pressure, secondary to the mass effects. Whenever the intracranial pressure is increased, either in idiopathic intracranial hypertension or any other situation, cerebral edema. So it's papilledema is an optic disc swelling, bilateral, usually bilateral due to increased intracranial pressure, secondary to the mass effect. It results from impaired exoplasmic flow in the optic nerve. On fundoscopy, we find elevated optic disc with blurred margins, as we have shown the picture. So elevated optic disc with blurred margins, that's a papilledema. And if it's present, that's a sign of hypertensive emergency, and immediately we need to lower the blood pressure. Retinal artery occlusion, it's the blockage of the central or the branch retinal artery. Why it occurs? Usually due to embolism from the carotid artery atherosclerosis. We saw that, right? It is the major, it can also cause amaurosis pubis. So blockage of the central or the branch retinal artery, usually due to embolism, carotid artery atherosclerosis is greater cause than the cardiogenic. and less commonly due to giant cell arteritis. It presents with acute painless monocular vision loss on fundoscopy. It's cloudy retina with cherry red spots at the fovea. So, like cherry red spots at the fovea, other than the Niemann-Pick and Tay-Sachs, the third differential is this retinal artery occlusion, right? Cloudy retina with cherry red spots at the fovea, identifiable retinal emboli. For example, cholesterol crystals appear as small yellow refractile deposits in the arterioles. So cloudy retina is there with cherry red spots at fovea, identifiable retinal emboli. For example, cholesterol crystals appear as small yellow refractile deposits in the arterioles. So mostly I think they are saying that cholesterol crystals will go and occlude it, right? Identifiable retinal emboli, cholesterol crystals
They
appear
may
as
be
small.
seen in the fundoscopy though. Yeah, that's what I say.
Cholesterol crystals appear as small yellow refractile deposits in the arterioles. Then retinal vein occlusion. So central retinal vein occlusion due to primary thrombosis or branched retinal vein occlusion due to secondary thrombosis at arteriovenous crossings. Why? Because the arterioles are thickened. So sclerotic arterioles compress the adjacent venules, causing turbulent blood flow. So arterioles are thickened. So sclerotic arterioles, they compress the adjacent venules, causing turbulent blood flow. On fundoscopy is the retinal hemorrhage and venous engorgement. So retinal hemorrhages and venous engorgement causes blood and thunder appearance, arrows and E, and retinal edema in the affected area. So retinal vein occlusions, retinal hemorrhages, and venous engorgement. So blood and thunder appearance will be there. Retinal edema in affected area. And retinal detachment, I've just mentioned separation of the neurosensory retina from the underlying retinal pigment epithelium, loss of choroidal blood supply, hypoxia, degeneration of photoreceptors, and these are rigmatomatous and non-rigmatomatous. Redness pigmentosa, which is associated with A-beta lipoproteinemia, these are the group of inherited dystrophies causing progressive degeneration of the photoreceptors and the retinal pigment epithelium. So photoreceptors are gone, which are rods and cones, and retinal pigment epithelium. Early symptoms, night blindness because of these photoreceptors loss, nyctalopia, and peripheral vision loss. Fundoscopy, we get a triad: optic disc pallor, retinal vessel attenuation, and the retinal pigmentation with bony spicules. Bone spicule shaped deposits will be there. So this is a very peculiar bone spicule shaped deposits. Retinal pigmentation with bony spicule shaped deposits, optic disc pallor, and retinal vessel attenuations would be there. But it's mostly they're associated with A-beta lipoproteinemia.
A-beta lipoproteinemia.
Yeah. Photoreceptors are degenerated and retinal pigment epithelium that leads to nyctalopia. What? Should we take some break, please?
Yes.
Thank you.
If you say so. Yes, let's take a break and come back.
Thank you so much.
Normal pupillary light reflex. Pupillary constriction occurs as a reflex in response to stimulation of the retina by light. Afferent fibers from the retina travel along each optic nerve to the optic chiasm, where they split and follow both optic tracts to reach the pretectal areas in the midbrain. Nuclei within the pretectal areas activate both of the Edinger-Westphal nuclei, each of which sends parasympathetic fibers down the ipsilateral oculomotor nerve to the ipsilateral pupillary constrictor muscle. Due to the crossovers in this pathway, light entering one eye causes both direct pupillary constriction in the ipsilateral eye and consensual pupillary constriction in the contralateral eye. Afferent pupillary defect is caused by a lesion in the retina or optic nerve. When light enters the affected eye, interruption of afferent fibers prevents both direct and consensual pupillary constriction. When light enters the unaffected eye, both pupils constrict normally. When the light is moved back to the affected eye, The pupils in both eyes dilate as they return to their natural state in a dark room.
Okay, now let's read and see if it makes sense. Not really, go back to it. So first, pupillary control, meiosis, pupillary light reflexes, mydriasis, and RAPD. So, okay, what we just did was a pupillary light reflex. Light in either retina sends a signal via cranial nerve 2. So we already saw on the reflexes page, 2 for afferent, 3 for efferent, right, for the light reflex. So here we have, first they're saying light in either retina sends a signal via cranial nerve 2. To the pretectal nuclei, which is the dashed lines in the image. Okay. So it's going from the eye to the pretectal nuclei in both eyes. Okay, simplified from your world, light entering is going to the pretectal nucleus via this yellow strand, which is the optic nerve. So light in the either retina sends a signal via cranial nerve 2 to the pretectal nuclei, which is where in the midbrain. Then this will activate the bilateral Edinger-Westphal nuclei. So these 2 pink ones are the bilateral Edinger-Westphal. And then it's just sending signal back via the ciliary ganglion to the eye. So activates bilateral Edinger-Westphal nuclei. Which muscle? Pupillary constrictor muscle. So it will constrict bilaterally. Direct and consensual reflex. Direct means whatever eye you're shining, the same eye will come back and it will also dilate. And it will also dilate the consensual, the other eye, where the light is not being shown, but that's consensual reflex. So the result is illumination of one eye results in bilateral pupillary constriction. So this is a normal expected pupillary light reflex. Illumination of one eye should result in bilateral pupillary constriction. So if there is a problem, that's when we have the afferent pupillary defect. So simplified again, when light is shown, light in either retina sends a signal via who? Cranial nerve 2, which is optic nerve. Where is this going? To the midbrain? Where in the midbrain? The pretectal nucleus. From the pretectal does what? It activates the Edinger-Westphal nucleus. Edinger-Westphal. Then what is it doing? So first synapse occurred from the retina going all the way into the pretectal nucleus. Second synapse is occurring from the pretectal to the Edinger-Westphal. So the pretectal is firing up the Edinger-Westphal. What will Edinger-Westphal do? Here it's taking via fibers oculomotor third nerve. This now it's getting signals, passing through the signals. They're passing through the ciliary ganglion. There is one synapse here. Then they're going and attaching to where? The pupillary constrictor muscle. So the input, which is light, which travels through the optic nerve, goes to the pretectal. And then again, signal is received through the Edinger-Westphal. Then going to oculomotor nerve 3 via the ciliary ganglion, goes and attaches to the pupillary constrictor muscle. So net result is when light is shown in one eye, it sends signal to the same eye as well as sends signal and comes back to the opposite eye. So there is a direct and consensual reflex. So this year they've given one step further. They've given the visual field on the left eye, on the nasal field. Yeah, temporal on this side, nasal on this side. So it's received the input when we shine the light. So this blue color, which is going from the temporal vision, is coming all the way, going across, going to the pretectal. From the pretectal, it goes to the Edinger-Westphal. Edinger-Westphal operates through the oculomotor nerve. They have a synapse in the ciliary ganglion, and then it goes to the sphincter pupillae muscle. So this blue one is going here and going all the way to this side, opposite side, and the same side as well. Technically, it should come. So this one is crossed here, so it's going to come to the same side and the consensual side. So temporal So markings: temporal retina, optic chiasm, lateral geniculate. This are the lateral geniculate going to the ipsilateral side. Crossed over fibers are also coming and collecting. They're all going to the pretectal nuclei. Pretectal say Edinger-Westphal. Edinger-Westphal say oculomotor nerve, ciliary ganglion में one synapse, and then goes back. Then these opposite fibers will also interact. Pretectal is triggering the opposite Edinger-Westphal. This is also going through the oculomotor nerve, ciliary ganglion, the opposite eye. So this is the direct and the consensual reflex. So
So Saira, sorry, lateral geniculate nucleus, basically it does not receive
contralateral.
Contralateral, just ipsilateral
Fibers, yes, correct.
fibers from the temporal side, right?
From temporal on each side, yes. Temporal on this side is red, so it's receiving to the lateral geniculate nucleus. Then here,
what is the role of lateral geniculate nucleus in light? These are the thalamic nuclei, right?
I think
they receive signal from the, I think, optic nerve, optic chiasma, and optic tract, and goes to the lateral geniculate nucleus, and these are for light thing. I think that's in the thalamus section they're written, but
I think they're more important when it comes to the other pathway, right? Which we'll see later. The
visual field effects.
Yeah, visual field.
Okay.
Because this is for the direct pupillary reflex and the consensual, but that's more for visual, like to interpret the whatever we are seeing. The geniculate nucleus come into play more over there. Here they just represented that the fibers are going. But for the pupillary reflex, this pathway is what is more important, right? This one going here, going to the pretectal, Edinger-Westphal, and ciliary and out. From here, it's going to the both sides. I think in the video that highlight was nice.
Thank you.
They didn't mention, actually, even in the text they didn't mention, they've just put it there. So here also they're showing it, but they're not even highlighting it, because I think this is not involved in the pupillary light reflex. It's only for the visual pathway.
Agree.
Yeah.
I mean, radiation, uske baad, after lateral geniculate, it formed the optic radiations and all this thing. Then it goes to the primary cortex and the visual.
Yeah. This is much easier and straightforward. Pupillary
no.
reflex is like involved there. This is what is involved. Yeah. Second nerve, input. Third nerve, output.
Correct.
What is the muscle? Superior sphincter pupillae we can add here. That's it. What is the nuclei involved? Pretectal first and Edinger-Westphal. That's it. We don't need to include geniculate in this story, actually. Okay, so then that was the normal pupillary light reflex, which we expect the patient to have. So uske pehle we have meiosis and mydriasis. What is meiosis? This is pupillary constriction. This is a parasympathetic effect. We know when we read, we want to rest and digest and read. We want meiosis, pinpoint pupils, so that we can focus and read. First, neuron, Edinger-Westphal nucleus, to the ciliary ganglion via cranial nerve 3. That's the first order neuron they're saying for constricting, for output to be constricted, pupillary constriction. Second neuron, short ciliary nerves to the pupillary sphincter muscles. Okay, so one is via the Edinger-Westphal and the cranial nerve 3 via ciliary ganglion. Second pathway for meiosis is short ciliary nerve to sphincter pupillae directly. So two ways meiosis can occur. One is this, actually not two ways. First neuron is Edinger-Westphal to the ciliary ganglion via cranial nerve 3. Second order is ciliary ganglion. This part is known as short ciliary nerve going to the sphincter pupillae muscle. Actually, so first order neuron, second order neuron. So short ciliary nerves shorten the pupil diameter. So that makes sense. Then next we have mydriasis. What is mydriasis? This is dilation of the pupil. It's a sympathetic response. So when we flight, we want the big pupil so that we can see properly, fully, all wide angle, and light will go in and vision will be wide angle, clear, distant vision also. So mydriasis is dilation sympathetic. What's the first order neuron? The hypothalamus to the ciliospinal center of Budge. Second order neuron, exits at the T1. So here you have 3 neurons, first, second, third. So first neuron, hypothalamus to the ciliospinal center of budge, C8 to T2. Second neuron, they exit at T1 to the superior cervical ganglion, travel along the cervical sympathetic chain near lung apex and subclavian vessels. So that's why this becomes important. If this gets, so these are normally carrying mydriatic fibers. If they get injured, that's why we have Pancoast tumor and all those things. We saw ptosis, meiosis, and hydrosis. Meiosis because mydriasis pathways are damaged. So the opposite will happen. Anyway, so first neuron, hypothalamus to the ciliospinal center of budge. From the hypothalamus to the ciliospinal center of budge. Then second order neuron is exiting at T1 to the superior cervical ganglion. Did they give an image? No. Travels along the cervical sympathetic chain near the lung apex subclavian vessels. Third order neuron plexus along the internal carotid through the cavernous sinus, enters the orbit as the long ciliary nerve. This is attached to the pupillary dilator muscles, which we saw. Sympathetic fibers also innervate the smooth muscles of the eyelids, minor retractors, and the sweat glands of the forehead and face. So, which makes sense that if the sympathetics are interrupted, ptosis, meiosis, and hydrosis. Long ciliary nerve makes the pupil diameter longer. Let me see. Okay, BNB. Yeah, here we go. This is all we need to know. So mydriatic pathway, first order neuron from the hypothalamus to the ciliospinal center of budge. Hypothalamus to the ciliospinal center of budge in the C8 to T2 levels. Then second neuron exits at the T1 to the superior cervical ganglion. Travels along the sympathetic chain near the subclavian vessels. Third order neuron plexus along the internal carotid through the cavernous sinus, enters the orbit as a long ciliary nerve and supplies innervation to the dilator pupillae. Dilator pupillae contracts. This is the one with a radial spoke, so it will open up. I mean, when it contracts, it opens the diameter. So pupil is dilated. These fibers are also carrying innervation to the smooth muscle of eyelids, minor retractors, and sweat glands of the forehead. So any of these, if it gets interrupted, ptosis, meiosis, and hydrosis. Let me check you.
I think if you open the Horner syndrome pathway, it will make, I think, more sense.
Check. This one, right? This is the pathway. So what is happening here again? From the hypothalamus, starting in the hypothalamus, autonomic regulatory nucleus of the hypothalamus, first order neuron is going up to the ciliospinal center of budge. That's where it is. Then from here, at the exit at T1 to the superior cervical ganglion. So that's the second order neuron. Travels along the cervical sympathetic chain, near lung apex subclavian vessels. Yes. So it's more likely to get injured because it's crossing close to the lung apex, so stellate ganglion can get involved. So as it's traversing through, this can get damaged. Then it's synapsing at the superior cervical ganglion. So third order neuron is from plexus along the carotid, which we saw the other day. So it's along with the plexus of the carotid. Its sympathetic fibers will also, okay, no. So along with the plexus along the internal carotid through the cavernous sinus, enters the orbit as the long ciliary nerve to the pupillary dilator muscle. And then as it passes along, it also innervates the smooth muscle of eyelids and sweat glands. So any interruption at any of this point will cause ptosis, meiosis, and hydrosis. Midriatic pathway is damaged, ending up in meiosis. Hypothalamus, P1, stellate ganglion, inferior cervical and superior thoracic ganglion, superior cervical ganglion, then along the ICA, carotid plexus, entering the orbit, ciliary ganglion, via the ciliary ganglion, and supplying the pupillary dilator muscle. So as we said, two portions of that iris muscle. One is the dilator muscle, the other is a sphincter muscle. So midriatic pathway is a dilator muscle. When it contracts, it lifts in such a way that the pupillary diameter will open up. It will be all around the eyes. It's three-dimensional. That's it. Sympathetic pathway done. Now, next we need to see what happens if anything gets damaged. But while we are here, pop memory jog. What do we know about this? What is this structure?
Mammillary body.
Nice. What was this structure?
Hypothalamus.
No, इसके जो बीक में
क्या वो peak पे hype नहीं है? Pituitary.
Pituitary.
Wow,
was this
Dr. Tim.
structure?
Pineal.
Nice. What is this structure?
Salem.
Vermis of the cell. Nice. It's coming together. So that's the pupillary dilation pathway. Now we have to see what happens if something goes wrong. So there is something known as a relative afferent pupillary defect. This is also known as the Marcus gun pupil. Here what happens, the extent of pupillary constriction differs when light is shown in one eye at a time due to either unilateral or asymmetric lesions of the afferent limb of the pupillary reflex. What's the afferent limb? Either the optic nerve, what did they say, or the retina itself. Retina itself or the optic nerve, because that's the input pathway, afferent. So yeah, what is relative afferent pupillary defect? Also called Marcus gun pupil. So extent of a pupillary constriction differs. Instead of normal, it's different when light is shown in one eye at a time due to unilateral or asymmetric lesions. So it'll only be one side. One side retina damage, one side optic nerve damage. So pupillary constriction differs. Normally it should be even on both sides. Here its pupillary constriction differs. Extent of the pupillary constriction is different in each eye when light is shown in one eye at a time due to unilateral or asymmetric lesions of afferent limb of the pupillary reflex, which is involving the retina or the optic nerve. So when light shines into the normal eye, let's say here this eye is damaged, either retina or the optic nerve. So when light shines into this normal eye, what happens? Constriction of the ipsilateral light will occur because this will go on a pathway and then this one is coming back and it's shining. So ipsilateral will be okay. When light shines into the normal eye, if constriction of the ipsilateral eye, which is the direct reflex, is okay. Contralateral constriction also, from here it will go and give this supply. So when we shine light on this eye, it's okay. This eye direct reflex is also there. Consensual is also intact. No problem. But when light is swung from this normal eye going to the affected eye, then what happens? Light is swung from the normal eye, now shining into the affected eye. Both pupils dilate instead of constricting. So let's trace that. So if this eye we're putting, what happens? When light is swung from the normal eye, now immediately we're going to the normal eye. So now this were already dilated from the first shine. This is also dilated from the first shine. So now when we swing the light to the abnormal eye, when light is swung from the normal to the abnormal eye, affected eye, what happens? Both pupils will dilate instead of constricting. So this pupil is not taking any input, actually speaking. This eye. But they will appear dilated because they've already dilated from the previous one. So normally what should they do? When light is shown, they should be constricted. But that's not happening. That's so-called a Marcus gun pupil. Let's see again. Also called Marcus gun pupil, the extent of the pupillary constriction differs when light is shown. So the difference in the pupillary constriction is the problem. That is known as Marcus gun pupil. The difference in the pupillary constriction. So this can be due to unilateral or asymmetric lesions of the afferent limb of the pupillary reflex, which is the retina, either the retina unilaterally or the optic nerve unilaterally. When light shines into normal eye, constriction of the ipsilateral direct reflex and the contralateral consensual reflex is observed. When light is immediately swung from the normal to the affected eye, both pupils are dilating now. They're dilating instead of the expected constriction. So that's the RAPD. Now let's look at that video again about the RAPD.
Normal pupillary light reflex. Pupillary constriction occurs as a reflex in response to stimulation of the retina by light. Afferent fibers from the retina travel along each optic nerve to the optic chiasm, where they split and follow both optic tracts to reach the pretectal areas in the midbrain. Nuclei within the pretectal areas activate both of the Edinger-Westphal nuclei, each of which sends parasympathetic fibers down the ipsilateral oculomotor nerve to the ipsilateral pupillary constrictor muscle. Due to the crossovers in this pathway, light entering one eye causes both direct pupillary constriction in the ipsilateral eye and consensual pupillary constriction in the contralateral eye. Afferent pupillary defect is caused by a lesion in the retina or optic nerve. When light enters the affected eye, interruption of afferent fibers prevents both direct and consensual pupillary constriction. When light enters the unaffected eye, both pupils constrict normally. When the light is moved back to the affected eye, the pupils in both eyes dilate as they return to their natural state in a dark room.
So they're returning to natural state, so it appears as if they're dilated instead of being constricted because we just shown light. So that's the relative afferent pupillary defect. Are we good?
So it
Thank
is
you.
because
And
of
that is MS, right?
So
Sorry?
it is because
It's a feature of multiple sclerosis, right?
Exactly. Yep. It's a feature of multiple sclerosis. Why? Because unilaterally there'll be patchy demyelination of the optic nerve and or the retina. Optic nerve actually for MS. Yes, this is associated with MS. Sorry, someone was saying something.
Yeah. I was just trying to rephrase that, saying that just because you've shown the light from one eye to the other one, it is the pass effect which is causing both the eyes dilate, right? That's what you're telling. Yeah.
Yep.
So this is MS. There's one more, right? Argyle Robert, that is syphilis. Okay, we'll come there.
Yeah, that is Argyle Robertson. That will come, I think, when we do the Argyle Robertson was accommodation reflex. When we do it, should come in. Yep, we'll come across it. If not, we'll do it for sure. Okay, so if this is okay, then we have left out few more things in the retinoblastoma. I'll get back to it. So are we good with this? Meiosis, what happens? Pupillary right reflex, what happens? Mydriasis, what happens? RAPD, what?
Please, after this, if you have some energy, please take a quiz from ENT side.
Sure, if you are ready, then I'm ready.
No, just to consolidate some things.
Yeah, we can do it, sure.
You're very good in it.
Who, me? In quiz? No.
Yes, no.
Asking questions, yeah.
Consolidate. You make things consolidate, seriously.
Okay, sounds good. Will do. Thank you. Okay, so we left out this retinoblastoma, leukocoria and uveitis. So, yeah, so just quick highlight points I wrote down. So drusen, think macular degeneration. Diabetic retinopathy usually will be cotton wool spots or maybe neovascularization. Macular star, buzzword for hypertensive retinopathy. Cherry red fovea, retinal artery occlusion. Blood and thunder, think retinal vein. Dark curtain and wrinkling, two things if they say, think retinal detachment. Bony spicules and pigmentation, retinitis pigmentosa. High VEGF, low VEGF, high VEGF, retinopathy of prematurity. Elevated and blurred, papilledema. These words, if you pick up, that'll get much, much easier as we go.
Sorry,
Awesome.
Saya, the last one. What is this? Blurred and irritated. And with
Elevated and
yeah, with retinopathy of prematurity, first is high, then low, and then high VEGF, right?
yes, this is in utero. This is at birth. This is few days after birth.
Okay. Okay. And what about this retinal vein occlusion you said?
Blood and thunder appearance. Khatarnak blood and thunder. Barish ke din, think retinal vein. So it appears like that because the vein is occluded and bleeds. So
Vein and rain, remember that.
vein and vein. Nice.
Thunder.
Hypertensive emergency. Yeah. Hypertensive emergency, the more I think specific thing is AV nicking. I saw in some question, I think. That's
Yeah.
that's how it sticks. AV nicking and hypertensive retinopathy.
Where did we see that AV nicking? Hypertension only, right?
Hypertension.
In the brain, hypertensive encephalopathy, somewhere we saw it. Yes, okay. Thank you so much. Yeah, I'm gonna write that. I like that. Vein and rain and thunder. That was a good one. Vein. Sorry, my thing is not working. Annotation. Vein, rain, and thunder. So blood and thunder appearance. Nice. Okay. So now we're moving on to retinoblastoma. So this is the most common intraocular malignancy in children. Arises from immature retinal cells. So this we are seeing the retinoblastoma caused by mutations to both RB1 tumor suppressor to both. This is where they test the double hit hypothesis. Both RB1 tumor suppressor genes on where chromosome 13, which normally impede G1 to S phase progression. So RB is the policeman preventing too much transition from G1 to S. So now this tumor suppressor is gone, uncontrolled proliferation from G1 to S phase. This can be sporadic or familial. Familial, if there's loss of heterozygosity, then it will present with the illness. How does it present clinically? Symptoms of leukocoria, which is white eye, loss of whitening of the red reflex, which we're going to see in a few. Strabismus, which is squint, and nystagmus, and red eye redness. Presents with what? Leukocoria, strabismus, nystagmus, red eye redness. Usually the question will have loss of whitening of the red reflex will be there, which is nothing but the medical term for that is leukocoria. Leuko is white, coria is the eye, I think. So leukocoria is the white reflex or loss of the red reflex. Loss of the red reflex such that it's white. Important causes in children include retinoblastoma and congenital cataract. So retinoblastoma, there's a tumor growing, so it won't reflect the light. Congenital cataract, the lens is already damaged or accumulating something, so that also won't reflect, won't give the red reflex. So yeah, that's it. Retinoblastoma, most common intraocular malignancy in children, arises from immature retinal cells caused by both RB1 tumor suppressor genes, mutations to both RB1 on chromosome 13, which normally impede G1 to S phase progression, can be sporadic or familial, presence with leukocoria, strabismus, nystagmus, eye redness. What is this leukocoria? Loss of the red reflex is known as leukocoria. So they're present with the white reflex. Important causes in children include retinoblastoma and congenital cataract. Okay, next we have uveitis. What is uveitis? Inflammation of the uvea. Specific name based on the location within the affected eye. So yeah, Then we said anterior. So uveitis ka parts, we said iris, choroid, ciliary, what was it? Ciliary body and the pigmented epithelium. So then they're splitting uveitis into anterior uveitis and posterior uveitis. Anterior uveitis means just the iritis inflammation. Posterior uveitis means choroiditis, and or it can spread to the retina, so retinitis also. So may have a hypopyon. What is a hypopyon? This is accumulation of pus in the anterior chamber or conjunctival redness. So they're present with hypopyon and conjunctival redness. What is this pyon? Pus accumulation in the anterior chamber. What is this associated with? Systemic inflammatory disorders like sarcoidosis, Behcet syndrome, juvenile idiopathic arthritis, HLA-B27 associated conditions. So yeah, we saw in Behcet the uveitis part, right? There we said more common in Turkish and Mediterranean populations. And then we said, what was the infection associated with? HSV. I remember Hamna said Ertugrul. So it's really what?
So what's the infection with Behcet? HSV?
HSV, yeah. HSV, I think.
HSV or Parvo? I don't know. I think HSV.
Both actually. Both.
Parvo and HSV. Okay, thank you.
Parvati ke saath Ertugrul. Okay.
Parvati ke
Virus. Sorry, I know his character is good in that, but anyway. HSV or Parvo with the P51. So both. And they have recurrent abscess also, genital ulceration, uveitis. So now we are reviewing this uveitis associated with Behcet syndrome. Yes. So then may have a hypopyon. Yeah. So we said association Behcet syndrome, juvenile idiopathic, HLA-B27, although Behcet was HLA-B51. Okay. So one more time, what is uveitis? Inflammation of the uvea. It could be anterior or posterior based on the location affected. Anterior uveitis is iritis. Posterior uveitis is choroiditis and or retinitis. They may have a hypopyon, which is accumulation of pus in the anterior chamber, or conjunctival redness. This image is showing conjunctival redness as well. Associated with systemic inflammatory disorders, example, sarcoidosis, Behcet syndrome, juvenile idiopathic arthritis, and HLA-B27 associated conditions. This was the PAIR, right? Psoriatic arthritis, IBD, and what was R for?
Reactive arthritis.
Thank you. Reactive arthritis.
Yeah.
P was psoriatic, A was ankylosing, I was IBD, and R was reactive arthritis. So they can all be associated with uveitis. Okay. And this they usually test. White reflex in child. What could be the other tumor? Osteosarcoma, because they have the same gene and so on. Or they'll test the two-hit hypothesis and so on. So yeah, that's retinoblastoma, leukocoria, uveitis. Okay. This is from immature retinal cells. Next, we have Horner syndrome. So that's the same pathway. So I think we can finish this also. So this is sympathetic denervation of the face. Sympathetic denervation of face. We have ptosis, meiosis, and hydrosis. Ptosis is a slight drooping of eyelid because of the loss of supply to the superior tarsal muscle. This, I think, is the question. Meiosis, pupil constriction, and hydrosis, absence of sweating, and absence of flushing of the affected side of the face. That also, because sympathetic effect is lost. Associated with lesions along the sympathetic chain. First neuron, what's the associations? We have pontine hemorrhage, lateral medullary syndrome, spinal cord lesion above T1, example, Brown-Séquard syndrome, and late-stage syringomyelia. So first neuron was the hypothalamus to this synapse in the lateral horn. So this can be due to pontine hemorrhage or the lateral medullary syndrome. Then a spinal cord lesion above T1, Brown-Séquard hemisection, late stage syringomalia can all affect the first order neuron. So that's the causes. Second order neuron, what could it be? Stellate ganglion compression by the Pancoast tumor is a second order neuron problem. Third order neuron, what could it be? It's passing along the carotid vessels very close to it. So carotid dissection. So it'll be painful. Anhidrosis is usually absent in this. Anhidrosis is absent, meaning double negative, meaning they will be able to sweat. Okay, then again, the image review. So this is the same thing we saw earlier. Hypothalamus to the synapse in the lateral horn. What was it? Budge, central area of... No. What was it? Yeah.
Spinal
Spinal center of budge. Right?
सर तो उसमें DSS के लिए था ना?
Yeah, I'm wondering if it's the same thing for this also.
हाँ, ये T1 तक जाएगा, I guess.
This is the same thing, isn't it? This is where the sympathetic pathway is going. I think it's the same thing. Let's see.
Yep. I think so.
It's carrying sympathetic fibers as well as it's sympathetic only, it's the same thing actually.
Yeah. Horners वाले में तो देखा था हमने this picture.
Yeah, exactly. True. Yeah. So, yeah, same thing then, same pathway. So first order neuron. So here actually they didn't give the name on first, they gave in the previous one, ciliospinal center of budge. So these are the possible causes in that area. First order neuron, pontine hemorrhage, makes sense, right? Midbrain pons medulla will be here. So pontine hemorrhage, lateral medullary syndrome, or spinal cord lesion, or Brown-Sequard syndrome, but before T1, because we know only in the thoracic we have the lateral horn with the sympathetic fibers. And intermediate horn it's called, I think. Then late stage syringomalia makes sense. The syrinx will expand and affect the sympathetic fibers as well. Second order neuron is here, Pancoast tumor with the stellate ganglion compression. Pancoast tumors, that's the possibility. Third order neuron, we saw it's running so close to the internal carotids. If the carotid is dissecting, it will stretch these fibers and cause damage to the sympathetics also. So that's this. And here's the same thing they showed, first order, second order. Third order is going to three things. One, it's going to the sweat glands of the face. Two is going to the eye and it's going to the pupillary dilator and the smooth, that's number two. Smooth muscle of the eyelid is the third one. So ptosis, meiosis, anhidrosis, and also so glands of the face and as well as glands to the forehead, sweat glands to the forehead. What is this nerve? Long ciliary nerve. Ophthalmic division of trigeminal is also with it, close to it. So long.
Explain this. Sorry, the figure. I'm so sorry for that. I just lost in that. Ciliospinal center of budge.
I got you. So I was just going to say long ciliary nerve makes the pupil diameter longer. Short ciliary nerve to shorten the pupillary diameter. So for meiosis, short nerve. For mydriasis, long nerve. Or easier way, meiosis is short word, so short ciliary nerve. Mydriasis, longer word, so long ciliary nerve, if they ever test that fact. So yeah, one more time, image review. We have from the hypothalamus, we are going first order neuron all the way to synapse in the lateral horn, which is the ciliospinal center of budge, which is located in the C8 to T2 area.
T2. Yeah.
So that's where first order neuron synapse is. Let me put this sideways. They've shown this. This is the left side inner surface. This we are looking at the right side inner surface. So that's how it's different. Same thing, same pathway, they've shown it in different ways. Different sides actually. So hypothalamus, how do we know?
Cerebellum is the posterior, cerebellum piece.
Exactly. Cerebellum is in the back. This
Look,
side.
look at the bird. Yeah.
And yeah, you can bird also, you can say.
With the crown and all those things. Yeah.
So yeah, cerebellum is here. So this is in the frontal side. Then here will be the eyes and nose. Actually, eyes is here, so nose will be here. It's a bad image, but yeah, it's important in neuronat. Anyway, so hypothalamus to the first synapse in the lateral horn. Second neuron is from this spinal center of Budge, traveling via the stellate ganglion, but not synapsing there. It's traveling up it, through it, and then synapsing in the superior cervical ganglion. That's a second order neuron. Third order neuron, from this superior cervical ganglion, it splits into the branch to supply the sweat glands of the face. Second branch is to supply the pupillary dilator as the long ciliary nerve. So it's entering along with the ophthalmic division of the trigeminal nerve as the long ciliary nerve and going to the pupillary dilator muscle. It's also giving off another branch to the smooth muscle of the eyelid. So that will be the tarsal muscle causing elevation. So if it doesn't work, there'll be depression, which is ptosis. Then it's also giving off some fibers to the sweat glands of the forehead. So again, injuries, what could be the potential causes here? Pontine hemorrhage, lateral medullary syndrome, Brown-Séquard transection at any of these levels, or late-stage syringomelia expanding the syrinx. What could be the problems in the second order? Pancreas tumor growing here and interrupting the fibers in the stellate ganglion. That's second order problem. Third order, what could be the problems? It's going so close to the external carotid artery that any dissection that happens in that vessel can cause these fibers to get compressed and cause the Horner syndrome. But the point to notice, if it's a third order neuron, anhidrosis is usually absent. Because the branches are separate, maybe it's already supplying. So the sweating is okay. The problem with the third order is usually maybe the fibers that are affecting the eye is only involved. So they may have ptosis and meiosis, but anhidrosis is spared. So that's the Horner syndrome.
Thank you. Thank you so much.
Thank you.
Okay, so first neurons basically from the hypothalamus to at the level of T1, if we keep it simple, right?
Yes.
Or whatever ciliospinal center of Budge. So from T1, it goes to the stellate ganglion, which is the second order. Yeah, second neuron, stellate ganglion, and third neuron. Basically, third neuron is superior cervical ganglion.
Yeah, starts at the superior cervical and splits into the branches. Especially if you're talking for the mydriasis, then we talk about it converts into the long ciliary nerve, passes via the ciliary ganglion, and then supplies the muscle.
Okay, and it divides into a long ciliary nerve, ophthalmic division of the trigeminal nerve, as well as these sweat glands of the forehead and smooth muscle cells of the eyelid, right?
No, I think it's passing along with the ophthalmic division of trigeminal nerve. This is not the trigeminal itself, right? It's passing with it. I think they're showing this yellow nerve. Isn't it? That's what I thought.
Yep. So three divisions है. एक sweat gland to face, another is the long ciliary, and third one is to the forehead, sweat to the forehead, sweat gland to the.
And that is splitting one small branch to the eyelid. This is for ptosis. This is meiosis, and hydrosis is both face and forehead.
So total 4 हो गया ना?
Yeah, this 1, 2, 3, 4 we can say. Yes. यहाँ पे 3 निकल रहे हैं. Then 1 is branching into 2 for the forehead and for the eyelid. For net result, 4 small branches. Yep.
And carotid artery dissection is above the level of the superior cervical ganglion, right?
I think so. Yes. Third neuron. Anywhere along this pathway. Anywhere along that. Carotid plexus.
Okay.
Second order, Pancoast. And the first order, which is Pons, pontine hemorrhage, lateral medullary, Brown-Séquard, all the major things, spinal cord lesions,
Yes.
and late-stage syringomelia as well. Okay.
Yes.
Thank you, Saira. Thank you so much.
Hey, listen, when you say anhidrosis is usually absent, so Horner syndrome, we know that there is ptosis, meiosis, and anhidrosis. So this is happening because something is affected, right? Something is getting cut or something.
Correct. The sweat glands are damaged, this fiber, if it gets
Damaged.
cut, then it
Damaged.
will cause anhidrosis. But they are saying with the third order neuron, if it's exclusive damage to the third order neuron, then the anhidrosis part is
Yes,
usually absent.
Basically, they'll be sweating a lot. That's all.
Exactly.
Yeah.
They'll be able to sweat. So this will be intact. This will be intact. They mean to say that third order neuron more likely to injure the long ciliary nerve,
Yeah. Yeah.
causing dilation problems, but they're able to sweat.
Thank
So
you.
anhidrosis is absent, meaning sweating is okay, normal.
Yeah. Mhm.
Thank you. So next, let's finish off with ocular motility. So this we are familiar, cranial nerve 6, LR6, SO4, remaining 3. LR6 for lateral rectus 6th nerve abducens, SO4 4th nerve superior oblique trochlear. Rest are supplied by the 3rd nerve, oculomotor nerve. Obliques go opposite. Left superior oblique and IO are tested with the patient looking right. IO is tested looking up. Inferior oblique is tested to look up. So inferior oblique, because they work via pulley mechanism. So inferior oblique, you ask the patient to look up and see if the movement is there, in and up actually for inferior oblique. Obliques go opposite. So obliques, inferior oblique, superior oblique. Inferior oblique on this side, superior oblique on this side. Superior rectus above, looking up. Inferior rectus look down. Superior rectus look up on this side, same thing. Superior rectus is also doing some outward direction. Inferior rectus is downwards. Lateral rectus, laterally, medially. This is straightforward. We know this. LR3, SO4, rests 3. The important related question for USMLE is the blowout fracture. So orbital flow fracture usually caused by direct trauma to the eyeball, or the intraorbital rim. So either the eyeball itself or the intraorbital rim. There's increased risk of inferior rectus muscle problem and or orbital fat entrapment. This may lead to infraorbital nerve injury. Yeah, they usually give this image and they ask what is the muscle involved. Then we should pick inferior rectus. And then there's another question they gave in UWorld with the lateral muscle in colored, and they asked what's the muscle responsible for. You're supposed to understand that that was a lateral rectus supplied by the 6th nerve. Then next we have strabismus, eye misalignment or crossed eyes, commonly known as squint. So deviation of eye towards the nose is known as esotropia, which is the most common type of strabismus in children. Complications include amblyopia, diplopia, and adverse psychosocial impact. Amblyopia, what is it? This is lazy eye. There's decreased visual acuity due to maldevelopment of visual cortex caused by abnormal visual experience in early life due to strabismus, typically unilateral. Yeah, this is very important to notice in children. If they watch TV, but they're looking through the side and watching, that's a sign that they're having a strabismus, and there's decreased visual acuity because they need input. So this decreased visual acuity is because of maldevelopment of the visual cortex caused by abnormal visual experience early in life due to strabismus.
What do you mean by watching through the side of the eye? You mean
they turn the head, and if you notice, kids do that. They turn the head and watch through the peripheral vision, to the side vision.
Okay.
Because of this misalignment, they try to correct that crossed eye like that. So
how do they correct you? Do you know how do they correct that? Recently, you tell me. Yeah.
The surgery, you mean?
No, they don't do it. Somewhere I read it's interesting, but if you know, you just share your information.
I've read it, but I'm not recalling right now. Please share.
You know, they close one eye, it seems. That's all. The other one aligns itself.
Yes, exactly.
I don't know where I studied. They just
put
close
an eye.
Yeah. It's funny. Yeah, but it's interesting. Yeah.
So that the other eye will show the visual acuity to the brain, and that doesn't interrupt.
Yeah, this aligns itself. It's naturally.
Yeah, that was very interesting. Yes, I think Yuval has a question about that too.
Don't
strabismus.
know. I don't know where I read, who spoke, somewhere I'm carrying this information.
That's good information, yeah. What did I do? Okay, here we go. Strabismus. Yeah, here we go. They have an image. So ocular misalignments towards the nose, esotropia is the most common. Ectropia is the opposite side, but I think that's not tested. So here, the oculocutaneous albinism is autosomal recessive disorder, melanin biosynthesis, typically due to defective tyrosinase. Patients have reduced absent melanin pigment in the skin, hair, and eye, as well as abnormal development of the fovea and optic nerve fibers, leading to reduced visual acuity and nystagmus. Let's see what else they checked. Improper alignment of the eye can result from disorders of the extraocular muscles or the nerves that innervate the 3, 4, or 6. Or the nerves that innervate them, so 3, 4, or 6. Untreated strabismus, misalignment of the eyes in early childhood, can lead to unilateral visual cortex suppression due to avoid diplopia, and eventually may lead to amblyopia, which is decreased visual acuity. Okay.
So when they say visual cortex, what exactly you mean? Which portion of the eye? Which portion of the eye?
What I understand is both the eyes, the retinas need to get stimulated to go to the brain and stimulate the visual cortex, right? It needs to go to the visual cortex.
Yeah.
So if that's not happening because they're trying to correct the diplopia, then this visual cortex does not get input, and that leads to misalignment. I don't know exactly the details.
Cortex, this term is so broad. That's why I thought, like, okay.
The visual center, basically. The what is it? In the broadcast page we see, right? The primary visual cortex.
Okay. I get you.
That would be this one in the occipital lobe.
Yeah, primary.
Eye and go and stimulate this area to make it like properly develop. But because of that squint, they doesn't happen. So that's why they close the eye, I think.
Yeah, okay.
So at least one eye.
Thank you.
What happens? Squint in one eye, like esotropia. So what would they do? What is amblyopia? Sorry, I didn't get it. In simple words.
Amblyopia is basically one side. So one side the muscles are not developed properly, correct? Strabismus. So because of this strabismus, what happens? Diplopia, they'll have double vision. Correct? Because they have double vision, they will turn to the side so that they correct the double vision, so that they prevent the double vision and they're able to see focused. So because of that, they're avoiding input from one eye. Something like that. Let me check actually. But then how does it help if we close it fully? I don't know.
So amblyopia is a lazy eye. What is this lazy eye thing?
Decreased visual acuity due to maldevelopment of visual cortex caused by abnormal visual experience early in life. Let me read this.
This is very interesting, lazy eye. And this is very common. You know what? I've seen kids with the nice glasses they put, and to correct it, they say. I never understood this phenomenon. You see, this guy has got, Yeah,
let's see. So strabismus vision disorder, the eyes do not properly align with each other when looking at an object. The eye that is pointed at an object can alternate. The eye that is pointed at an object can alternate. Okay. The condition may be present occasionally or constantly. If present during a large part of childhood, it may result in amblyopia or lazy eyes and loss of depth perception. If onset is during childhood, it is more likely to result in double vision. Strabismus can include muscle dysfunction, farsightedness, problems in the brain, trauma, or infection. So any of these causes. We were reading specifically of the muscle dysfunction, esotropia, but it can be any of these causes. Risk factors include premature birth, cerebral palsy, and a family history of the condition. Types include esotropia, so inward deviation, where the eyes are cross-eyed. Okay, yeah. Exotropia, eyes diverge outside. Lazy eye or wall-eyed. Hypertropia, one eye is vertically misaligned. Or they can also be classified whether the problem is present in all directions a person looks, competent, or varies by direction, incompetent. Diagnosis is made by observing the light reflecting from the person's eye and finding that it's not centered on the pupil. This is known as the Hirschberg reflex. Another condition that produces similar symptoms is cranial nerve disease. Treatment depends on the types of strabismus. This may include the use of glasses and possible surgery. Some types benefit early from surgery. Strabismus occur 2% of children. Strabismus means a squinting. The wall of the eye has been used. Okay, let's see. So amblyopia. This can occur for poor alignment of the eyes like strabismic, an eye being irregularly shaped that is such that focusing is difficult, or one eye being more nearsighted or far-sighted than the other, refracted errors, or clouding of the lens of an eye. After the underlying cause is addressed, vision is not restored right away as the mechanism involves the brain. Amblyopia can be difficult to detect. So a vision testing is recommended for all children through the ages of 4 to 5. Treatment includes wearing an eye patch on the stronger eye. That's what we're doing. Treatment eye patch of the stronger eye. By covering up this eye with a stick-on eye patch, similar to a band-aid, the brain has to use a weaker eye to see. So some kids only need to wear the patch for 2 hours a day, while others may need to wear it whenever they are awake. Yeah, nice, makes sense. Thank you. So amblyopia begins at the age of 5. In adults, the disorder is estimated to affect 1 to 5 population. Blah, blah, blah. So yeah, basically because of strabismus, one eye made is straight okay vision, the other one is not working, right? So what happens? They try to turn the eye and use only one eye more. So what happened? Input from the other eye and the other side of the visual cortex is not going to develop properly. So what do? The normal eye is patched off, so that purposely the patient has to try to use this squinted eye so that the visual cortex does get representation and then it will be developed properly. So yeah, if patient has a strabismus and it's not corrected, then it can lead to amblyopia, which is known as a lazy eye, which means one eye is lazy. It does not detect the vision properly. Decreased visual acuity due to maldevelopment of the visual cortex caused by abnormal visual experiences early in life due to strabismus, and it's typically unilateral.
So means वो जो strabismus वाली आई थी वो lazy आई है, उसको वो use नहीं कर रहा था.
Yes, correct. तो उसकी
तो अब
visual
हमने
acuity कम हो जाती है.
उसकी विजुअल एक्यूटी कम हो जाती है, तो अब हमने पैच नॉर्मल आई पे लगाना है.
हाँ, जितने जल्दी हो सके, as soon as possible, when you see a strabismus, we should do it so that we avoid lazy eye. This, अगर without knowing, if they leave it, that's when it becomes the amblyopia. हाँ, तो इसमें, okay, let's say we diagnose कि amblyopia थोड़ा set in हो रहा है, then what do? We patch the normal eye, so the patient is, this lazy eye is forced to be used, right? Lazy को jogging करवा रहे हैं हम लोग basically. So lazy eye has to work more, represent in the visual cortex, so that side, both sides of the visual cortex get representation, like from it's getting signals from both sides, and so the visual cortex will be properly developed. Needs input, right? So that's what they're saying.
Yeah, thank you so much.
Thank you.
So normally in strabismus there is diplopia. They see double things like normally.
Because one eye is straight, the other eye is mixed, like moved, right? It's a medial deviation in case of esotropia. So how will they focus on the object? One eye is giving this direction, the other is giving ulta direction. So they'll have double vision, two representation on the retina. So that's why.
Good. Can you label? Can you just go with the labelings of these muscles? Sometimes.
Yeah. Oh yeah. Sorry, actually I didn't do the image review for this. So we have superior rectus superiorly. If this contracts, it will pull like this. So what happens? It will elevate the eyeball. Inferior rectus is on the lower surface. So if it contracts, it will pull the eyeball down. Then lateral will pull laterally, medial will pull medially. The only unique thing is about this inferior oblique and the superior oblique. They work through this pulley type system. So you see here there's a trochlear attachment. So if it pulls, it kind of pulls it in the oblique direction. So that's why they said inferior oblique is tested looking up. You have to ask the patient to look up, and this is the right eye. The patient has to look up and left, right, up and out. Up, right eye means up and out, right?
Why do you think it's out? It's in. It's in.
Up and in.
Yeah.
Yeah. This is the midline. So this is 2 eyes. This is the left eye, right eye. So up and in. And for this one, inferior oblique will be no, inferior oblique is up and in. Superior oblique will be down and in. So obliques, inferior oblique, IOU, we test looking up. Obliques go opposite. So left SO and IO are tested patient looking right. Obliques go opposite. So left superior oblique and inferior oblique tested with the patient looking right. That part I'm not clear.
So
Go ahead.
superior name is superior. It is supposed to be superior, but superiors is stretching to the inferiors. And IO is the inferior, which is making it to look opposite. That is superior, right? Means inferior oblique, the patient would be seeing, means not a patient, normal person would be seeing up and inside, right? So isn't it opposite to the name? That's what oblique goes opposite.
Okay. So oblique will go opposite. Can you repeat that again? Sorry, it's not clear.
So inferior means niche, right? So inferior niche location to niche. If you see, the location is down, but it works the way to move the eye opposite, like superior side mein, like upar or inside dekhega.
Yes, because it's a pull thing, so it will pull it upward. So we're testing it above. Yeah. Correct.
Exactly. Or oblique hai, matlab the way to remember, right? If I'm thinking about my right eye, ठीक है? So if I need to see oblique, so अगर बाहर की तरफ देख रही हूँ, तो that is the superior rectus, that's fine. But when I'm seeing inside oblique side, so that is the inferior oblique, inside oblique, right? Means up and in. Oblique हमेशा, हाँ, oblique is always तेरह ना, like in between 90 degree there is something 45 degree में, right? So the way to remember, like not logically.
Yeah, I understand the action key is superior oblique, how it will work. This mnemonic I'm not relating to actually.
हाँ, वो oblique है ना, so inferior oblique location पहले यहाँ वाले side पे देखते हैं हम. Can you see the muscle? Yeah, no, the other one, another picture, more left, right. So कहाँ पे inferior है? नीचे है ना, नीचे. Inferior oblique is down. हाँ, when it pull, like when it is stretched, then I would go opposite, that is superior side. So that is why they are saying oblique is going to making it opposite movement.
Okay. Inferior oblique and superior oblique do the opposite movement. Okay.
That is only this.
Inferior oblique, but you ask the patient to look up.
नाम भी opposite है.
Okay, understood. Now I understood. Thank you. Yeah, makes sense. Okay, so LR6, SO4, R3. So this page is done. I think we're good. Maybe a few time for quiz if you guys are okay. Right, we'll stop here. I think we should continue tomorrow. This kind of, right? What do you guys think?
I think so. You're right. we can do it tomorrow.
7, 8, 9, 10, 11, 12 pages. Okay, decent. Can do it.
नहीं 12 भी नहीं 11 ही है सारा.
हाँ, okay, yeah, I think I counted the
70 we did already. बस 2 ही caption and एक और कोई है ऊपर में, और कुछ नहीं.
It's okay. Yeah, nice. Okay, quiz. Ready? Everyone should participate. Hamna ke saath saath. Then only it's more fun. Okay, let me see. Me pause. Stop recording actually. You guys want the quiz to be recorded?